COVID webinar which we are conducting. The aim of this webinar in the present scenario is that there has been a lot of hue and cry about the efficacy, hesitancy, and the effectivity of the vaccine. So today we are fortunate to have a galaxy of speakers, moderators and chairpersons who are going to deliberate the common issues about the basis of development of the immunity, especially when it is concerned in immunocompromised state. So we have different speakers who will be telling us about how the immune response develops in COVID-19, especially in special situation where the immune system is compromised. Is it efficacious? Should it be given? If it is given, what are the side effects? With that, may I request Dr. Ashish to start the proceedings.
Yeah. Good evening, ladies and gentlemen. I bring you greetings from Sir GANGARAM Hospital, and on behalf of Delhi Liver Foundation, I welcome you to this interesting webinar on COVID vaccine and special population. So without wasting much time, I would like to invite our chairpersons for this meeting. The chairpersons are Dr. Saurabh Mukhewar. He's a consultant at Midas Hospital, and he was also an assistant professor of medicine at Cornell University as well as Columbia University. He has been trained in US. And the second chairperson is Dr. Prashant Solanki, who's a gastroenterologist at Tirupati Liver and Gastro Care Center at Meerut. So I would welcome both the chairperson and hand over the proceedings to the chairpersons to conduct the further meeting.
Okay. Hi, good evening, everyone. Thank you so much, Ashish. And thank you, Dr. Arora, for inviting me and Dr. Prashant Solanki for the event today. Dr. Solanki, will you be taking care of the introductions for the topics and speakers?
Yeah. Good evening, everybody. This is a wonderful opportunity to talk on such an interesting topic, that is COVID-19 vaccination in special situations. And as Dr. Arora said, we have a galaxy of learned speakers and moderators here who are going to talk about this special topic. The moderators are Dr. Piyush Ranjan. He is a very senior faculty member at Sir GANGARAM Hospital, and Dr. Guru Iqbal Singh ji. Both are very learned in clinical gastroenterology and clinical medicine and have numerous publications. So I would like the moderators now to take over and introduce the speakers so that we can go on and proceed with this feast of knowledge.
Good evening, everybody. So to set the ball rolling, we have Dr. ANIL Arora, who is a chairman, Department of Gastroenterology in Sir GANGARAM Hospital. He is ex-president INSL, and in fact, he's a very accomplished gastroenterologist, does not need any introduction to this audience. And he will set the ball rolling with the basic pathophysiology of the immune system and the immunocompromised patient, which will kind of set the tone for the further talk. So without much ado, I'll invite Dr. ANIL Arora to deliver his talk, and subsequently, Dr. Jaya will introduce the next speaker. Dr. Arora, please.
Thank you, Dr. Piyush. Is my presentation visible?
Yes, sir. We can see that.
Okay. So what I'm going to talk for over next 20 minutes is the pathophysiological basis of immune response in patients with COVID-19. I may not be specifically concentrating on immunocompromised setting because so far as we understand the basis of immunity, so wherever there is a lack of immune response for different reasons, be it the B cell or the T cell, you're going to land up in trouble. And I'm sure my learned colleague will be talking of individual deficiencies of the immune response. Way back in December 2019, an ophthalmologist on 17 December noted a atypical type of pneumonia and tried to warn the Chinese authority that there is something amiss in this type of pneumonia. The guy was arrested and later on he died of COVID-19. But in December 2019, only the Chinese authorities started realizing they are up with the atypical pneumonia, And credit to them for all the criticism they have borne over the years. With credit to them, we know that within a month of knowledge of this virus, by January 2020, they came up with the genetic code of this virus. And what has happened over the next 2 months, since the WHO took almost another 2 months to declare that this as a pandemic. So the Chinese who fought this virus all over the globe, resulting in the misery which we are seeing today, with almost till today evening, 17.6 crores of the people have been affected, resulting in the deaths of about 38 lakh individuals all over the world. Once the virus enters the body through the oropharynx as well as into the lungs, our immune system, whether it is circulating or it is present in the innate state in the surrounding tissues, this starts reacting. So what is this virus? This is basically a single-stranded virus which has multiple proteins to which the body reacts. In fact, 27 proteins have been described to which the body may end up reacting. Typically, the virus, which is by definition an enveloped virus, is endocytized into the cell, infecting cell through the ACE2 receptors. And once it is endocytized into the epithelial, let's say type 2 alveolar epithelial cells, the first contact of the inhaled virus, it is fused with endosomes or lysosomes, and the virus is disintegrated into the various components. Now, since it is a single-stranded, positive-stranded RNA, so it just uses the intracellular machinery to produce large amount of the components of the virus, which are again reassembled and extruded out into huge number. So this is what happens. The virus has entered into the cell. In the normal course of the events, once the virus is lysed in the cell, it will release a number of components into the cytoplasm. And God has given us enough protective mechanism to counteract this. These are called intracytoplasmic TLRs. So they will try to neutralize this. In a normal course of the events, once you have a foreign material which lands up into the cytoplasm of a human cell, there is an activation of the supranuclear receptor, which tries to initiate NF-kappa B and interferon. This interferon from an infected cell migrates to the neighboring cell. Mind you, the cell which has been infected with the virus cannot be prevented from dying or from getting infected. But the interferon goes to the neighboring cell just to warn it that there is an incoming virus, please take care of it. So interferon moves into the surrounding tissue, gets attached to this receptor at the surface of the next cell, and leads to stimulation of the interferon stimulating gene, which prevents the entry of the virus into the next cell. So in the normal course of the event, what happens? You have a virus which enters into the epithelial cells. As the virus gets lysed, the cells tend to express this antigen with MHC class 1 and antigen receptor complex, to which CD8 cells come back and recognizes it well, and the virus is lysed and the virus infected cell is killed. At the same time, once the virus infected cells is killed, a large number of the antigens are released, which are picked up by the antigen presenting cell, and then they are provided to the helper cell or CD4 cells. This CD4 cell has an advantage of releasing interferon and change over the T0, that is TH0 cell, naive T cells, into a TH1 cell, which has a property to release interferon, which is going to go and kill the cell. At the same time, with the help of another cytokine called IL-4, it will stimulate the B cell development, resulting in the formation of the antibody. But virus is smarter. Mind you, it is important to remember that the reason virus is able to infect the human body, it has a trick up its sleeve to evade that immune system. This is a smart virus. It has developed the mechanism to evade the attachment of the lysosome to the incoming virus. It tries to degrade the various intracytoplasmic receptor. It tends to prevent the stimulation of the interferon stimulating gene to produce interferon, and it acts at a number of areas by which it evades the immune system. So what is happening? You have evaded the first defense, that is interferon production within the cell. So virus makes merry. It enters a cell. You have a ready-made machinery to translate the mRNA into multiple proteins. All these proteins are again assembled into the beautiful spiky proteins and the covered virus called, that is the reason it is called a coronavirus, because it looks like a crown prince, and then large number of the virions are extruded into the circulation. At the same time, because the virus is not able to have interferon stimulation, because the virus is suppressing interferon stimulation, so you have large number of the virus which comes out into the surrounding cells. Surrounding infected cells tend to release an interleukin called interleukin 6. This has three properties. It is important to realize that it alters the balance between Th1 and Th2. So Th1 is suppressed. It also decreases the cytolysis and the cytolytic capacity of the CD4 and CD8 cells. It also decreases the apoptotic capacity by increasing the expression of the PD1 onto the surface of the infected cells. So here you have large amount of the virus, which is causing release of interleukin 6, which is preventing the action of Th1, decreasing the cytolysis of the infected cells. That means infected cells continue to grow and produce more and more virus and infect more cells. And it also prevents the apoptosis of the virus. So what does it result into? In a normal course of the event, the virus which was eliminated, somehow, because of the release of the interleukin 6, you have the naive T cells now get transferred and get converted into Th17, which is a pro-inflammatory cytokines. And as the T cells and the other cells are expressing PD and PD1 receptors onto the surface, so the macrophages and the CD8 cells are not able to kill them. So here is a virus which is preventing the apoptosis, cytolysis of the infected cells, and is changing the balance of the helper T cells toward Th17 cells, leading to a huge amount of inflammation, which is the cause of mortality in patients with COVID-19 infection. Let's see, what do we do when we give vaccination? Let's talk of a Covishield vaccine. What is this vaccine? It is a DNA-based vaccine in an adenovirus, in which once you have a spike protein, which is available in the DNA of this adenovirus vector, it is endosized into the vaccinated cell. From there, the adenovector is lysed. Part of the DNA containing the genetic material for the spike protein goes into the nucleus. From there, the DNA is converted into mRNA. mRNA comes out into the cytoplasm, and then this mRNA certainly is translated to produce a large amount of the spike protein. So the mRNA which is present in the cell which has been vaccinated comes out onto the surface of the cells in the form of spike proteins. And once the spike proteins are available, they are picked up by the antigen presenting cell, depending upon whether this is a MHC class 1 or MHC class 2, you have activation of the helper T cells. These helper T cells, if they are of CD4 variety, they are going to have stimulation of the antibody response, whereas if there is a attachment of the MHC2 receptor with the CD cell, there will be activation of the CD8 positive cytotoxic lymphocytes. So once T helper cells, that is CD4 cells, are activated by the incoming antigen which has been given to it by the antigen processing cell, it leads to stimulation and proliferation of the B cells, which leads to production of the large amount of the antibodies which are available to this spike protein. So these viral antibodies coupled with the T cell stimulation by the incoming antigen leads to a combination of the T cell mediated immunity as well as the antibody immunity, resulting in the destruction of the virus, which is extruded from the body and is taken care of. Now, let me give you the components of how this T cell gets stimulated. Once you have an antigen presenting cell, which has brought the spike protein into the T cell receptor, which is naive, this is called TH0. Let's see what happens. In T cells, once they are exposed to this APC presenting as MHC class 2 antigen, it takes the dendritic cell takes this antigen into the lymph nodes. In the lymph node, the naive T cells are converted either into CD4 positive cells or CD8 cells. Now, once there is a stimulation by this antigen, there is a proliferation of these cells, and these naive cells get matured as either T helper cells or cytotoxic T cells, depending upon the attachment of the antigen which has been brought by the antigen presenting cell, whether it is MHC1 or MHC2. So the naive T cells are converted into mature T cells. What do they do? Once they are present in the lymph nodes, they tend to proliferate because of the release of the interleukin 2. You have large number of the T cells, which are now called as effector T cells or the memory T cells. And once they are available, they move out into the circulation and they have a plethora of action. These include by the mechanism of direct toxicity, CD8 cells will directly kill the infected cells. CD4 cell also can directly kill the cell, or it can induce macrophages or other cells of the immune system to cause inflammation and get rid of the virus. So you have circulating immune cells, which can be going anywhere depending upon the site of the infection. So prior to the onset of the infection or exposure of the CD4 naive cells to the antigen, these and epitopes have a very poor capacity to bind to the antigen, the virus. But once there is a stimulation of the T cell by the incoming antigen, our T cells become very robust, they become more powerful and more effective. So what type of T cells do we have? We have Th1 cells, which will try to kill the virus by releasing interferon. We have Th2 cells, which are extremely important in stimulating our B cells to produce an antibody response. And then finally, you have Th17, which is typically shifted in balance in patient with COVID-19, which will recruit large number of neutrophils, which are responsible for unfortunate deaths in about 1 to 2% of the patient infected with hepatitis B, infected with COVID-19. And finally, you have a suppression of the Treg cells, something which is important for the tolerance of the body. What about the B cell? Same antigen which was being brought to the lymph node by the antigen presenting cell also helps the T cells to stimulate the proliferation of the B cells. So once you have a subset of the B cells which has come in contact with the antigen through the help of T helper cells, so they will start producing antibodies to begin with IgM, and then there is a class switching of the antibody from IgM to IgG, and finally there is something called affinity maturation, which is extremely important. That means you have high affinity to expressing B cells. The cells which are producing antibodies can either become B memory cells or they become high affinity IgG producing cells. And once you have antibodies, all of us know they can either neutralize, opsonize, or produce antibody mediated toxicity to get rid of the virus. So how does it happen with B cell? Now, again, as the virus has been brought into the lymph node with the help of antigen presenting cell, the naive B cells get stimulated by the CD4 helper cell, that is Th2 helper cells. So this leads to the interaction of the B and C cell, B and the T cells, which lead to the activation of the B cells. Once the B cells are activated, you have a subset of the cells called T follicular helper cells, which are extremely important. I'll come to this again. So this leads to proliferation of the plasma blast, which gives you large number of antibodies like IgM, IgG, or IgG. It also leads to production of something called pre-germinal center memory B cells. So this leads to initiation of the germinal center response, which takes place within the lymphoid tissue. Now, T-B cell interaction leads to rapid proliferation of the B cells and gives rise to production of the low affinity antibody. Now, see, this is what is happening. So you have antigen T cell is trying to stimulate B cell to produce antibodies. But then if these antibodies are still friendly, they do not have high affinity. Unless you have repeated exposure and this pre-germinal center moves into the germinal center. Now, because of the repeated proliferation of the B cells which have been exposed to the antigen, there is iterative cycles of proliferation, maturation, and repeated DNA arrangement. This leads to selection of the best cells, best B cells, which are going to have the maximum affinity for binding the antigen. This is called affinity maturation. This is an extremely and cardinal step in understanding the immune system, which is related to the B cell. So what are the cardinal features of the memory? You have something called affinity maturation. That means the B cells, which typically, let's say, has only 5 receptors on its surface to bind an antigen. Because of the iterative cycles of proliferation, mutation, as well as repeated DNA rearrangement, now you have maturation of the germinal center. That means you have these cells which are expressing higher width of the receptors, which much better affinity to bind than what was possible in the initial phase of the response. And some of these cells will develop into plasma cells, which are the cells which the only function of these cells is to produce antibodies. Some of these will produce memory cells, which will move into the bone marrow, so that you have high affinity antibodies which are present. So this is what happens. Now you have after the maturation of the B cells into the germinal cell, you have a B cell which are smaller in size and had few receptors become a cell which has a high affinity to a multitude of receptors. So this is called maturation affinity. So to tell you what memory is of two types. You have an immediate and persistent memory. This is by preformed antibodies which are given to you by plasma cells. So if plasma cells have given you enough preformed antibody, so as soon as the virus enters into the body, you will have no reaction. It will be totally the patient will be totally asymptomatic. You get rid of the virus because the virus will be completely neutralized. But let's talk of a situation 6 months down the lane from today when the antibodies are not present by the preformed antibody from the plasma cell. This is the time when there is a stimulation of the pre-existing memory cells. And I have shown you that pre-existing memory cells, even if they are present in the germinal center or into the bone marrow, they have more affinity and they have much better response to combat the incoming pathogen. In addition, this affinity maturation also involves the placement of B cells, memory B cells in the plasma and the plasma cells in the bone marrow niches, something which is important as the age becomes an important factor. So what is the antibody response to the incoming antigen on exposure? If you look at the initial response, because the antigen has come in contact with the B cell for the first time, B cells take time to migrate to the lymph node. So there is a delay in the response. Initial response is from the naive cells getting converted into plasma cells. And as most of these plasma cells will ultimately die with passage of time, so your antibody levels come down. Look at what happens with the second exposure or the booster dose of the vaccine. You already have a preformed memory cells, which gives you immediate increase in the antibody as compared to delayed response in the first instance. You have a higher level and higher number of the plasma cells with higher affinity, lasting for a longer period of time and continue to be there for a longer period of time. So every time you are exposed to an antigen, you have a higher response of higher affinity, leading to more memory cells. Some of these memory cells will ultimately land up in the bone marrow. So what factors decide what will be your antibody levels? Age is important. Prior exposure to the antigen is extremely important. And then the vaccination schedule and the vaccination dose. Only thing you have in your control or modifiable factor is the age at which you vaccination or give the vaccination at a given schedule. You do not have a control on the previous exposure and you cannot have a control on the vaccine dose because that has already been determined by the clinical trials. We know that T cell depletion occurs with age. So this is an important data to understand that thymic epithelium space starts decreasing from the first year of life at a rate of 3% until middle year. And after 45 years, 1% of the thymus dies. And by the time you are 100 years, the T cell is totally gone. And there is a direct relationship between the T cell and the age. With increasing age, you have no T cells to take care of the infection. That is the reason the mortality is highest in the older age group. Other factors which determine the response are in addition to the age include again, the children's age. Children by definition have less developed ACE2 receptor and are less likely to get infected. They do not have bone marrow niches, which I showed you, which are important for storing the memory plasma cells. By default, they have good T cell response and hence are able to get rid of the virus quickly. And because of the frequent occurrence of the common cold virus in children, they have a good cross reactivity in the childhood. Sex is an important feature because T cell depletion typically does not occur as well in females as occurs in males. And hence all of us know that mortality in COVID-19 is almost 2 times in males as compared to females. Other parameters of response include the site of infection as to where does the virus start from and also the root of the infection. And hence new concepts are coming in that a nasal vaccine, which will prevent the very entry of the virus into the body, may be more important. So overall, a young female with good nutrition and nutritional status and immunocompetent person will have a much better response in both in terms of primary and secondary immune response compared to a person whose old age, is male, has poor nutrition, and has an immune compromised status. So these are the basic tenets of immune response. To sum up, ladies and gentlemen, memory is the cardinal feature of the adaptive memory. So once you have an infection, it tends to stimulate the adaptive immunity by stimulating the production of the B and T cells. These small army of the cells which are specific to the infectious agents are able to combat the infection by producing the maturation and stimulation of these cells. With passage of time, however, the virus will go away. Once the virus goes away, the specific B cells and T cells, they tend to wane off, but you have persistence of some of the cells going to respond to you in case there is a recurrence of infection or repeat exposure to the infection. To sum up, what we do in COVID vaccine-induced immunity is that we try to limit the pathogen's life cycle. We activate other components of the immune system like interferon gamma or neutrophils or natural killer cells or macrophage, which will try to negate the pathogen. We tend to distribute the immunity to the various parts of the body by circulating the stimulated and effector T and B cells. And this has, and also try to give you sufficient affinity to the relatively low amounts of the antibodies, which will be effective in neutralizing the incoming pathogen, even if it comes for the next time. And we hope that memory cells remain in the body for a longer period of time. So even if there is a repeat infection, it will be covered up very well. With that, I'd like to acknowledge the contribution of my senior resident Ashok, who spent his important days for helping me prepare this presentation. Thank you. With that, I'll stop sharing and give it back to the organizers.
Thank you, Dr. Arora, for that brilliant talk. You have just refreshed our memories of immunology and simplified the entire complex topic by your brilliant cartoons. Ashok has also done a lot of hard work in this. So we'll have questions at the end of the session. Dr. Ashish, is that right?
Questions at the end. Questions.
So with this background, may I request Dr. Gurukbal Singh to introduce the next speaker and
thank you, Dr. Piyush Ranjan. I'm indeed glad to be involved in this event as a moderator, courtesy Dr. ANIL ARORA. And I am indeed happy to be listening to such excellent presentations. We have had one, and I'm looking forward to the second from Dr. Gautam Mehta, who I believe qualified from the Southampton University in 2001 and underwent postgraduate training at the Hammersmith Royal Free St. Mary's and Charing Cross hospitals. He was the youngest appointee to the Northwest Thames Gastroenterology and Internal Medicine Registrar rotation, and is currently a Wellcome Trust Research Fellow at the Institute of Hepatology, University College London. He is widely published and regularly teaches on MR, CP, PACES preparation courses. So over to you, Gautam, on current strategies for vaccination of patients with liver diseases, and look forward to your views on the importance of early vaccination for all these categories of people with chronic liver diseases, in particular, cirrhosis specifically.
Thank you very much. I'm very happy to be with you today, even though I'm in London. One day we can meet again in person, I hope soon. But I'll talk to you about what the strategies are for COVID-19 vaccination, liver disease in Europe in particular, and hopefully we can extrapolate the discussion to Asia and India as well. So thank you very much for the invitation. I hope you can see my slides. So what we'll talk about is, firstly, we'll just recap how COVID-19 has been such a big problem for our patients with chronic liver disease and liver transplant patients. We can discuss what is different about liver patients and their immune response and their biological response to COVID-19, because this informs how we manage them. We'll look at what is the available data on vaccination for chronic liver disease, liver transplantation. There is not so much to disclose that early on, but we'll see which studies are in progress and what is the future outlook for how we can manage this while we're waiting for more data to arrive. So let's just go back to the beginning of this pandemic. Dr. Arora already talked about how the pandemic started in Wuhan. It came to Europe very soon. These were the first patients that were really characterized with liver disease from Lombardy in North Italy. This was around 1 year ago now. But this group were really the first group to look at cirrhotic patients in a systematic way. And they showed very clearly that there's something different about the cirrhotic patient who develops COVID-19. The first thing is that a significant portion have a liver-related progression, liver-related mortality. In this case, maybe 1/3 of patients, unlike the typical pulmonary deterioration you see in the majority. And it's very clear that liver disease has a very important impact. So when you look at patients by MELD score, stratified by MELD, the very high MELD, the MELD 15 high MELD patients have very poor outcomes with COVID-19 infection, unlike those with less severe liver disease. And the mode of progression is through progression to multi-organ failure. So this is the CLIF organ failure score. It's used widely in Europe, as you probably know. But the CLIF organ failure score with patients with multi-organ failure had markedly worse outcomes, suggesting that multi-organ failure or progression to multi-organ injury is a mode of progression in COVID-19 in liver disease. So it was very quick. The hepatology community were very quick to set up registries of these patients to get more data. The COVID Hep registry is from Europe, Secure Cirrhosis from the USA. I know there are also similar data from India as well, I think from Dr. Sarin's group as well. But it's very clear that with increasing severity of liver disease, you will have higher requirements for intensive care, for organ replacement, and also worse outcomes in terms of mortality. And we talked about age as being a risk factor. So again, if you don't have cirrhosis, then you maintain this inverse pyramid. We know that the elderly individuals are the most likely to succumb to this disease. But if you have cirrhosis, this is completely lost, this relationship. So really, even younger patients with cirrhosis can have poor outcomes. So it's a dominant factor predicting outcome in COVID-19. And just to show you a little bit more data from these big studies, the mode of progression of disease in COVID-19 infection does seem to be decompensation if you have severe liver disease. So you see here that a large proportion of patients with Child-Pugh-B or Child-Pugh-C have a liver-related decompensation as part of their COVID-19 infection, which is unusual compared to what we know about the natural history of COVID-19. And again, the mortality is related to the degree of organ failure. So if you have a non-cirrhotic background, then actually your outcomes are still relatively good, even with progression to organ failure. But this is not the case with more advanced liver disease, and actually advanced liver disease with multi-organ failure has a very poor outcome. And this has been shown even in a propensity score matched model. So I think it's very clear these cirrhotic patients are in need of protection. They have very poor outcomes with COVID-19. Why might this be? Well, we can speculate and we can discuss this more. I think on the background of the really excellent immunological talk we just had, we can talk about what's different in liver disease. But this was an early paper from last year from China. This is one of the first papers that showed that transaminases in particular, liver markers, are independent predictors of outcome in COVID-19. But what's interesting is that this group suggested that there's direct infection of hepatocytes with COVID-19 virus. Of course, we at the time thought that's very unlikely because ACE2 is not expressed in hepatocytes at baseline. But it rapidly became clear when you look at the literature that ACE2 can be induced in hepatocytes in the context of chronic liver disease. So individuals who don't have underlying chronic liver disease will have very limited exposure of hepatocytes to the virus, but that's not the case in more advanced liver disease. And this may be why in some of these patients, tunnel here is a stain of cell death. You see quite widespread cell death on immunofluorescence on liver histology for these patients. And so one hypothesis that we've taken forward in our group in collaboration with people in the US is that cell death pathways are very important in the progression of COVID-19 infection. And actually in chronic liver disease, if you have hepatocytes that are expressing pathways of inflammasome activation, and they're also prone to viral infection because of ACE2 expression, then that might be one mode of progression to multi-organ failure in patients who have an underlying cirrhosis. Okay, so the topic that we are focusing on is vaccination, and of course it's the main way we can see ourselves getting out of this problem we're in. And the studies have been very, very thorough and very large, but there are very few liver patients that had clinical trial data. The three main licensed vaccines that we use in the UK and Europe, the Pfizer vaccine had only 3 patients out of 43,000 in clinical trials that had underlying chronic liver disease. AstraZeneca, even fewer, 0 patients with chronic liver disease in 11,000 participants. And the Moderna vaccine, there are a small number in placebo in the vaccine group, but there's no subgroup level data reported. So really, from the clinical trials, we can infer very little from what's published so far. And is there a reason to be worried about efficacy of vaccination? Well, I think the short answer is yes. We just had a very thorough review of the immunology of COVID-19, but of course, chronic liver disease per se has got several avenues of immune dysfunction. And we know a lot about the innate immune dysfunction that's been very widely studied in cirrhosis and alcoholic hepatitis. But there's also adaptive immune dysfunction in cirrhosis, both in the T cell and in the B cell compartments, a lot of it related to checkpoint receptor expression. So there are reasons to be wary of the current vaccination schedules. We know, for example, in pneumococcal vaccine that cirrhotic patients have both reduced peak levels of serological response to vaccine and also less durability. So this study from McCashlin about 20 years ago now showed that by 6 months, the levels of IgG from pneumococcal vaccine are very low in cirrhotic patients. And we know the same is true for hepatitis B, for example. So there are certainly reasons to be concerned. And another point I'd like to mention, which we haven't seen much real world data to support, but there is the potential for non-specific immune complexes causing harm with vaccination. So we know that some conditions have antibody-mediated enhancement as a mode of progression of disease. We saw very clearly in the last talk that antibody-mediated immunity is a very important part of vaccine protection. But if the vaccine response is suboptimal, if there are low titer of antibodies, or the antibodies are of poor quality because of a lack of affinity maturation, etc., then actually circulating opsonized virus, antibody virus complexes, can be non-specifically taken up by Fc gamma receptors. So here, this is a non-specific uptake of the antibody virus complex. And this non-specific uptake can lead to downstream pro-inflammatory responses through endosomal signaling. So there's a theoretical risk if people are suboptimally vaccinated and then get affected by COVID-19 in a third wave. Let's hope that doesn't happen. There is the theoretical possibility of enhanced pro-inflammatory response. Okay, so I think when you look at the real world data, though, on the whole, we can be reassured. These are UK data I wanted to share with you. You may have seen a lot of the other data, but these are quite new. In the UK, we've been vaccinating by age. So a lot of the individuals over in these groups, which is ages 70 to 84, 60 to 70, or 50 to 60, have been vaccinated. And this is the time between 2020 and 2021 here on the x-axis. And you see that the triangles are the nucleocapsid antibody seroprevalence, which has been fairly constant around 15%, suggesting background exposure. But of course, you see that the spike antibody responses have gone up very high to over 90% in all these 3 age groups as the vaccination has been rolled out. So from a population level, I think we're very happy with efficacy. And of course, long-term data are still awaited, but we'll see. The other thing that's unusual about the UK is that we have separated our doses by around 12 weeks for both Pfizer or mRNA vaccines, as well as adenovirus-based vaccines. And this gives us some chance to look at the longevity of a single dose and durability of response. So these graphs on the right, you see this is Pfizer dose 1, this is AstraZeneca dose 1. These are population level data, very large data sets. And this is the odds ratio for infection all the way up to around 12 weeks after that first dose. So if we start with AstraZeneca, you see that the odds ratio for infection, as you'd expect, falls very nicely with 1 dose of vaccination. You see the error bars start to widen at around 12 weeks. But interestingly, with Pfizer, you see this uptick after around 9, 10, 11 weeks, which suggests that maybe there's a waning of efficacy after 1 dose at that time on a population level. We don't know about this dose regimen in clinical trials, of course. So just some suggestion that repeated dosing is likely to be required. Okay. So what do we know about liver patients? We know very little about cirrhotic patients. I'll just disclose that up front. We know something about liver transplant recipients. This was published in JAMA earlier this year from the US. They looked at a large cohort of solid organ transplant recipients after 1 dose. This is a single dose of mRNA vaccine. But what you see is that after 1 dose in liver transplant recipients, the majority have an undetectable antibody response. So 50 out of 78, nothing at all. They then followed this up and looked at two dose responses, and things are certainly better. So what you see here is that this is the anti-RBD of the spike protein. This is anti-S1 of the spike protein antibody response. The individuals where there is a line connecting had a detectable after dose 1 and have had an increment after dose 2. The dots are those who had an undetectable after dose 1, and you see that a large number now have a detectable antibody response, but a significant number also still have nothing. And that's true for both total spike and RBD. And if you look at the numbers, around 20% still have a completely undetectable serological response to vaccination after 2 doses. Now, of course, there's no control group. These are just real-world data. And we also don't know what very importantly, we don't know what the surrogate for effective immunity is in terms of quantitation of that antibody response. Both important things we need to find through long-term follow-up. But this paper from Israel did have a control group, and I think this really highlights the problem even better. So this was real-world data again. These were mRNA vaccine recipients, the Pfizer-BioNTech vaccine, 80 transplant recipients, and some healthy controls. And again, the positive response is very low. It's less than 50%. And even in those who do have a positive response, you'll see that the quantitative response is lower than the healthy controls. So again, some reason for concern. And as you may expect, the predictions of vaccination failure were a higher age, high dose immunosuppression, or a lower EGFR. So what do we need to do? There are a number of studies looking at cirrhotic patients and looking at liver transplant patients in more detail. I see from clinicaltrials.gov that there is one in Delhi, which is brilliant, run, I think, from Dr. Sareen. Then we are running a study in Europe. This study is run through UCL, through my institution, but also through the European Foundation for Chronic Liver Failure, ELITA, which is the European Liver and Intestinal Transplant Association, and the Foundation for Liver Research, which is based in London. And this is looking predominantly at cirrhotic patients, also post-transplant, and we'll sample these patients post final dose. But importantly, we have the capacity to follow them up for a year and look at what efficacy looks like in these individuals. Okay, so I'll stop there. I'll just summarize by saying that I think I've shown you that COVID-19 has a very poor outcome in cirrhotic patients. So there's great need to protect these patients. The mode of disease progression may be different because there may be more hepatocyte cell death and decompensation, unlike the non-liver cirrhosis cohort. Hepatocyte injury is probably quite likely to underlie this. We don't have a lot of data for cirrhotic patients. We have some data for liver transplantation, and the efficacy seems to be lower. We definitely need prospective studies, and I'm very happy to talk more about that, or even to collaborate with any of you that's listening on trying to answer these important questions. And this is how to get in touch with me if anyone would like to. And I'll stop sharing there. Thank you.
Thank you, Gautam Mehta. I think back to the first moderator for the next speaker. We'll have question answers at the end.
Thank you, Dr. Gautam. So next we have Dr. Mohan Das. Dr. Mohan Das is a senior consultant working in the field of GI oncology, has got a lot of pioneering work in the field of GI epidemiology of the Indian epidemiology of GI cancers in India. And today he'll be talking about current strategies, when and how to vaccinate patients with cancer and organ transplant. Dr. Mohan Das, please.
Hello.
Yeah.
My screen is visible?
Yeah, we can see your presentation, Dr. Mohan Das. Yeah, please go ahead.
Okay. Thank you. Good evening to all of you, and thank you, Anil, for inviting me to give a presentation. And particularly, I want to thank you because it made me read up, and I came across these two interesting articles, which I would strongly recommend all of you read. One is Vaccinated but Not Protected, Living Immunocompromised During the Pandemic, written by Lindsay, who is taking rituximab for a medical problem. And the other was, which was just alluded to, antibody response to two-dose SARS-CoV vaccine in a solid organ transplant recipient. I took the test, and I got a certificate from Howard, who has unfortunately quit as the editor of the JAMA network, following some controversies recently. If one were to look at this very recent paper published a few days ago in Nature, a large number of people have been given the vaccine all over the world. But if you look at India, just over 10% as of today have been given the vaccine, and less than 4% has received both the doses. If one compares with Israel, you see that most of the adults in Israel have been vaccinated, and the schools and public places are now open for almost life as usual. So there is a fair amount of data from all parts of the world on efficacy, and I will try to go through some literature selected which is relevant to our topic today. So one of the first questions that come up is, are patients with cancer and transplanted patients at increased risk of COVID and getting serious illness or dying from it? So let us look what the literature shows. This is a very recent study published in the JCO, which is the leading journal of oncology. A large number of patients from 50 US medical centers, out of which 3 lakh patients had cancer. About 16% of them became COVID positive, and they all had increased all-cause mortality, which was about 20% more than, because cancer patients, you know, a lot of them died because of the disease. So there was a 20% increased mortality in cancer patients who got COVID. What they found in the multivariate analysis is old age, male gender, patients with hematological cancers, patients having multiple comorbidities, patients having tumors at multiple sites, and patients who received cytotoxic chemotherapy had increased mortality. However, patients who received immunotherapy or targeted therapy did not have increased overall mortality. So this is quite similar to what was presented in the previous two talks, that there is a susceptible group in whom the immunity is failing, and this kind of fits into that situation. So you can see here, that is patients, cancer patients, large numbers who did not have COVID, and this is the curve of patients who had COVID as well as cancer. This is another interesting paper published in the JNCI, looking at the prevalence and outcome of COVID infection in cancer patients, and this was from the Veterans Affairs. So the Veterans is a very big department in the US, and all the veterans are, you know, well looked after through the Veterans Healthcare System. So they had about 20 to 23,000 cancer patients in that veterans group who were tested for COVID. 8% were positive. That's about 1,800 patients. And the prevalence of COVID was similar across the age of the veterans. But what is most interesting is you can see this dark red bar in the middle. That is the excess of mortality or whatever. So as far as hospitalization goes, there was a 12% excess hospitalization rate amongst those who are having COVID. There was a 12% excess ICU admissions. There was a 7% excess respiratory support, needing ventilatory support for these patients. And there was almost 11% excess mortality, which is quite similar to the previous. So this is exactly what is the problem, that cancer patients have excess hospitalization, more ICU and ventilatory needs, and also more mortality. We heard about a little bit about the problem of COVID in solid liver transplant patients. And there are plenty of such studies. Usually most of them are ecological or just surveys or some using databases and small in number. So this is one such study, solid organ transplanted recipients with a matched cohort of non-transplant recipients. They had small number of patients and found that there was increased mortality, there was increased hospitalization, increased ventilation, as it was with the cancer patient. I will now show you a bigger study and a better designed study. This is again a solid organ transplant network using propensity matched analysis. So in this, they had about 2,300 patients who underwent solid organ transplants and almost 230,000 patients who did not have solid organ transplants who had COVID-19. The solid organ transplant patients were likely to be of high risk type. They were older males, higher BMI, had more comorbidity, hypertension, diabetes, ischemic heart disease, and CCF, and were nicotine dependent. So when they looked at the solid organ transplant group as compared to the whole group, they found that there was an increased mortality, but in the propensity matching, they created a group who was matched to this kind of patients in terms of these comorbidities, etc. And they found that the increased risk was almost entirely due to the high burden of comorbidities in these patients. In the solid organ group, transplant group, they found that there was an independent association with increased admission as well as acute kidney injury in these patients, but not mortality. And so this is the Kaplan-Meier curves. You can see that unmatched, there is a difference between those who did not receive transplant versus those who received transplant. So the mortality in those who received transplant was about 4.8% compared to 1.9% in the group that did not receive the transplant. But on matching, which they created 2,289 patients, an equal number who met the same criteria, you see there's absolutely no difference. So comorbidity, which is associated with these diseases, are also very important. So we can conclude from these papers that yes, irrespective of the mechanisms, cancer and transplanted patients are at increased risk of getting hospitalized, using the ICU and dying from COVID-19, and therefore they must be prioritized in the vaccine program. The next question comes is, will a patient with cancer or transplant benefit from getting the COVID vaccination? So in India, we have now 3 vaccines which are available. Sputnik is just being rolled out in very selective manner. We have our own Covaxin as well as the Oxford vaccine, the Covishield. Most of the literature is based on the Covishield. We have a few publications, public domain data regarding Covaxin. So let me just run you through some of the studies. This is a study that's looking at the Pfizer as well as the AstraZeneca vaccine on clinical outcomes. I'm not talking of seroconversion and spike antibodies to the spike protein, but actual clinical outcomes. What does it show? And that too in high-risk individuals. This was a case control study. So vaccination with either one dose of the vaccine was associated with a significant reduction in symptomatic COVID-19 in older adults and further protection against severe disease. Both vaccines showed similar effects. Protection was maintained during that entire period of the study. And the second dose of the Pfizer vaccine was associated with further protection against symptomatic disease. An effect of vaccine against the variant was also found. So in other words, at least in one group, that is the older individuals who are at the highest risk of dying from COVID, the vaccine does help to protect. We have evidence for that. Now, what about, so this is a pooled analysis of 4 randomized trials which were done using the Oxford vaccine. And in this, what they found is in participants who received 2 doses of standard doses of vaccine, the second one, the second efficacy was higher with a longer prime boost interval. So what they found is patients who received the second dose at 12 weeks had a 81.3% vaccine efficacy compared to those who had the vaccine at 6 weeks or less than 6 weeks, where the vaccine efficacy was 5.1%. This is in the 4 original studies where the Oxford vaccine was evaluated. This is a study looking at cancer patients. So safety and immunogenicity of 1 versus 2 doses of COVID vaccine in patients with cancer. This is an interim analysis. So they had a small number of patients included in the analysis. 151 patients with cancer, including solid cancers as well as liquid cancers, as well as 54 healthy controls. And they looked at anti-spike antibodies 21 days after the single dose. So what did they find? 94% of healthy controls had spike antibodies compared to 38% with solid cancers and 18% with hematological cancers. After the second dose was administered at 21 days, 100% of healthy controls had seroconverted and had antibodies, compared to 95% in solid cancers and 60% in hematological cancers. The antibodies were the vaccine was well tolerated, no major side toxicities, and no vaccine-related deaths. So these data support prioritization of patients with cancer for an early 21 days second dose, which is what was used in this schedule. This study was already alluded to, and I suggest that all of you read that. So you'll see that after the first dose, a large number of patients had either no antibodies or low antibodies, and even after the second dose, less than 50% had only achieved a high level of antibodies to the spike proteins. So they conclude that the spike antibody response in transplant patients after dose 2 compared with dose 1, and these data suggest that a substantial proportion of transplant recipients are likely to remain at risk for COVID-19 after the second dose of vaccine. But this I must add that we are only looking at a secondary endpoint, which is the antibodies. The prevention of the infection happens by more than one mechanism, and we don't know how the T cell mediated immunity is going to protect them, and we need to look at that as well. This Israeli study has also been alluded to, and we see that between healthy controls and transplant recipients, the conversion rates are low. There are several well-planned studies that are underway. There is an OCTAVE study which is running in the UK, led by the MRC and Birmingham Center, which is looking at patients with cancer, inflammatory disease, who are getting anti-CD20 antibodies, kidney disease, liver disease, transplants, etc. And I think this will give us some, more reliable information. And similarly, there is the VOICE trial running in Holland, which is again looking at, they have various groups, patients with no cancer, immunotherapy, cancer, and chemoimmunotherapy who are being monitored. And these two studies will definitely give us more level 1 evidence for the use of vaccine in this subset of patients. So based on these studies and others, which I'm not alluding to for the want of time, many patients with cancer or transplant do benefit from the vaccination. However, the seroconversion is blunted in many in comparison to healthy individuals. And therefore, these patients will continue to need other measures to prevent the infection. Now, what are the guidelines by various societies, the oncology and transplant societies? You'll realize if you read the guidelines that most of these statements are not based on, are based on common sense and not on high-level evidence. And there is usually a disclaimer to this effect, which is mentioned. The National Clinical Cancer Network is a very large organization in the United States looking after the clinical oncology. And they have come out with guidelines in January. The preliminary recommendations are as follows. Patients with cancer should be prioritized for vaccination and should be immunized when vaccine is available to them. Immunization is recommended for all patients receiving active therapy with the understanding that there is limited safety and efficacy data in these patients. Reasons for delay of vaccine are similar to the general public, that is recent exposure to the virus or cancer-specific factors, and vaccination should be delayed for at least 3 months following hematopoietic transplantation or CAR-T therapy. And caregivers and household contacts should also be immunized when possible. So they have given a breakup of different types of patients. So those who are undergoing hematopoietic therapy and CAR therapies, at least 3 months after the therapy, they should get vaccinated. For hematological malignancies, which is the highest risk group among cancer patients, delay till the absolute neutrophil count is recovered, and then the patients can be vaccinated. Marrow failures, long-term maintenance therapy for chronic um, hematological cancers, vaccinate them when the vaccine is available. I generally ask my patients to also check the platelet count, and if it is, and make sure that it is not low, for the simple reason that they may get a hematoma at the puncture site, and I ask them to keep the pressure at the puncture site for some more time. For solid tumor malignancies, those patients who are receiving cytotoxic chemotherapy or targeted therapy or immunotherapy, radiation, or undergoing major surgery, the vaccine should be given when it is available. And for surgery, separate the date of surgery from the date of vaccine by a few days. And this is important because these are the people who are constantly in touch with these patients, and they all should be vaccinated as soon as it is possible. There are individual country-wise guidelines. For example, this Australian guideline, COVID vaccination in people with immunocompromise, published recently. There are society-based guidelines like the ECEL position paper on the use of COVID vaccine in patients with chronic liver disease, hepatobiliary, as well as transplant. So these are some of the guidelines, the recommendations. They are, by and large, they are quite similar among the various societies. The various transplant societies across the world have come out and given a joint guideline, which I thought would be, we can go through it a little more. And this is the joint guidelines. Until more complete data is available, we urge pre-transplant vaccination of all solid tumor candidates as a priority when feasible. Continued vaccination in solid tumor recipients and priority for their household members and caregivers to reduce the risk, exposure risk to these patients. Continuation of stable immunosuppression regimen at the time of vaccination to avoid the risk of organ rejection until more comprehensive data is available, and continued adherence to all transplant recipients to protective measures, including masking, social distancing, regardless of the vaccine status. This is India's vaccination status as of yesterday. 14.6% of population has received one dose, and just 3.4% has received the second dose. So we have a huge challenge ahead of us, and our patients will continue to remain at risk. And we really need to push for relaxation and see that all our patients get the vaccine, even though only 40 to 50% of them may be protected with the vaccine. And along with the patients, all the caregivers should also get the vaccine on a priority basis. So the general guidelines against the fight against COVID remains: wear a mask, wash hands, keep distance apart. And these are some posters brought out by our CHAM School of Public Health for India, along with the India group out there. So there are different kinds of masks, and we commonly see patients wearing these masks, the cloth masks, which are not at all effective. And to be effective, they should at least wear 2 masks. But in general, I think it would be a good idea to recommend our patients to wear a N95 mask that will be 95% effective. Thank you very much.
Thank you, Dr. Mohandas, for that really exhaustive and comprehensive review on the topic. Very up to date. I welcome Dr. Sareen, who has just, I saw some time back, joined the webinar. Dr. Ashish, do we go ahead with the felicitation right now, or do we wait for the other 2 presentations?
I think we'll continue with the presentations. And then...
Thank you. Thank you. So welcome, sir. And Dr. Gurickbal Singh, would you like to introduce the next speaker, please, sir?
The next speaker is Dr. Rupa Banerjee. who's currently director of IBD at Asian Institute of Metrology in Hyderabad, also is on the research faculty of the Asian Institute of Basic Sciences in Hyderabad. Her key interest is in luminal gastroenterology, which includes IBD, that is ulcerative colitis and Crohn's disease, and also GERD. She is an active researcher in epidemiology, microbiota, genetic and enzymatic profiles for optimizing and individualizing management of IBD. She has a big database of some 4,000 patients and a biorepository dealing with their demographics, type and course of disease, diagnostic dilemmas, and response to treatment. She's also created recently a group of 16 countries from South Asia and Middle East. This is the Emerging Economies group on IBD. And of course, she has been conducting the biannual, once in 2 years, alternate years, AIG IBD Summit, and with some 1,000 delegates from India and neighboring countries have been participating. So we look forward to Dr. Rupa Banerjee's talk on efficacy of vaccination for patients with IBD and those on immunosuppressants.
Thank you, Dr. Jaya, for the kind introduction. And I must thank Dr. Anil Arora for giving me the opportunity. I think the previous talks have been fantastic and we have covered a lot of ground. My topic is relatively simple. What about vaccination efficacy in IBD? And I added the little bit below that to say, what do we know now? Because this is an area which every day there are new publications, new papers, we are learning, and COVID has actually taught us that we need to keep ourselves updated, perhaps even on a daily basis. So this is what the COVID-19 pandemic is, and you can see the kind of involvement across the globe. And for the first time, I suppose, India get close to just a virus. On the other hand, we have IBD, a chronic lifelong disease with increasing numbers being reported in India, a slow pandemic or epidemic across the globe. And you can see the suffering. I've put a picture of the Blue Lady by Picasso just to depict how silently people suffer. As the world continues to grapple with the COVID-19 pandemic, management of patients with IBD requires special considerations because these are patients who are malnourished, immunocompromised, and therefore at high risk. The medication protocol needs to be maybe modified. There are issues of hospital visits for follow-ups, infusions, performance of elective procedures, and surgeries. The low resource settings of the developing world has additional challenges. And we just realize that even in a country like India, there is a problem of access to care, availability of drugs, diagnostic dilemmas. Rural and primary healthcare network is actually ill-equipped to deal with IBD with limited resources, management facilities, or physician awareness. Just to tell us, we actually rang up more than 1,000 patients during the first wave and the lockdown. 35% of patients said they did not get any medical consultation even when they needed it. 7% visited, only 7% could visit their doctor in person. Among the patients on biologics, 22% actually missed their scheduled dose due to inability to visit the infusion center or non-availability of a local infusion center with expertise. 10% of sick patients stopped their IBD medications as in the melee. So the picture is difficult. The only thing that can protect these IBD patients is the big umbrella of immunization. IBD patients on immunosuppressants rely on vaccination and perhaps herd immunity to protect them from infection. What are the issues with IBD during the COVID-19 pandemic, the vaccination issues? Should IBD patients be vaccinated? Does immunomodulatory therapies impact antibody response? And of course, which is the preferred one? Should they be vaccinated? Yes, vaccination works. And I think the smallpox story tells us all. Because if you see here, there was back in 1947, 6 million New Yorkers got a shot to protect them from smallpox in just 1 month. There was, of course, the usual Board of Health notices, the quarantines, the social distancing, but this was the game changer. 6 million lined up in 1 month to get the vaccination for smallpox. And then we could say that smallpox is dead. And I think this is what all of us physicians, gastroenterologists, and every stream, as doctors, as a community, we are looking for when we will say corona is dead. So does immunomodulatory therapy impact the efficacy of vaccines? And we'll have two sets. One is background. What about the non-COVID vaccines? What happens in the immunosuppressed with the non-COVID vaccines, particularly in IBD? And then, of course, the evolving current data, the COVID vaccines. So if you see first, there are numerous studies that the pneumococcal vaccine response are impaired in those on biologics and on IBD. And if you see this very clearly, the response is, vaccine response is much lower when there are additional biologics or immunomodulators plus biologics, and therefore that gives us an inclination of what to expect from the corona vaccine. Similarly, influenza vaccine responses impaired in patients on combo therapy. Again, the response is lowered. And if you see this chart, the reduction in seroprotection, it goes higher as you use anti-TNFs, biologics, immunomodulators. So there are numerous studies which have now shown that vaccine response is going to be less in the immunocompromised. If you see vedolizumab, which is a gut-selective biologic, if you see response to hepatitis B and oral cholera vaccines in vedolizumab in exposed healthy subjects, interestingly, you can see that the anti-cholera toxin, the level is, the antibody level is much lower. So all patients should be brought up to date with all immunizations prior to initiating vedolizumab therapy. Perhaps the same applies for all the biologics and immunosuppressants, but COVID-19 is an entirely different scenario because you have to act now and then you have to take the steps. So evolving current data on COVID-19 vaccines, and the first thing to mention is there is limited data on vaccines specifically in patients with IBD, because most of the studies, for obvious reasons, because they did not want stoppages of the study and they did not want risks, so they have excluded patient groups with IBD from phase 3 vaccination studies. However, the first paper that came in April 19th in gastroenterology, IBD patients taking biologics achieved a positive antibody response to both the Moderna and Pfizer COVID-19 vaccines. These are not available here, but just showed that they did achieve a positive antibody response. The recent clarity, it came from the Clarity study. So this is actually the paper in IBD and vaccination strategy, which has given us very important information. So the first two papers from the Clarity IBD study have been published. Impact of biologic therapy on SARS infection and immunity. So if you see, there are two things. It was a 40-week prospective observational study of almost 7,000 patients receiving infliximab or vedolizumab immunosuppressants together at 92 UK sites. So there were two parts of the study. The first, if these people, they got COVID, what was the immunity following infection? And the second one, immunity following vaccination in those who received it. This is perhaps a very elegantly designed, excellent study to come out in these COVID times. So immunity following infection, magnitude of antibody. So if a patient gets infected with the COVID virus, magnitude of antibody is lower than the general population. It is lower with infliximab than with the gut-selective vedolizumab. And if you see that in infliximab patients on biologics, even with infection, the seroconversion rate is just 48%. Without immunomodulator, perhaps 60%, but with immunomodulator, a meager 37%. And that is a matter of concern. So anti-SARS-CoV-2 antibody reactivity, if you stratify it by biologics and time since the infection, even then the antibody levels on those as marked in gray, the ones who were taking infliximab continues to be low. It's the vedolizumab where the antibody levels are seen to increase over maybe 2 to 3 months as well. So immunity following infection, the summary, fewer than half of people with IBD treated with infliximab had detectable antibodies after infection. Concomitant immunomodulator use, such as a thiopurine or methotrexate, further blunted the serological responses. Now coming to the immunity post-vaccination. What happens if IBD patients on biologics, on immunosuppressants, they are taking the vaccination? And if you see here, again, whatever be the vaccine, it is infliximab has a lower spike antibody concentration post the first dose of vaccine. With vedolizumab, the level remains high. So percentages of participants with seroconversion, again, if you see here, infliximab with immunomodulator, infliximab without immunomodulator, much lower with or without immunomodulator compared to vedolizumab. And mind you, again, to highlight that vedolizumab is the gut selective, perhaps causing lesser immunosuppression here. Now, if you classify it based on biologic therapy, prior infection, number of doses, and vaccine type, the picture is very clear. With first dose, the antibody response appears to be inadequate. With the second dose, both with infliximab or vedolizumab, the levels are much better. Similarly, if a patient has an infection and gets the vaccine after that, meaning thereby a second dose of immune stimulation, the antibody levels look to be high. So summarily, after a single dose of vaccine, only 1/3 on infliximab had adequate levels of antibodies. However, even if there was a previous COVID infected or with the second dose of vaccine, the antibody response was adequate. So effective antibody response only after 2 doses. The summary of this finding: after first vaccine dose, antibody concentration lower with infliximab than vedolizumab. Older age, immunomodulator use, Crohn's disease, and current smoking associated with lower antibody concentration. This might be interesting to us. Non-white ethnicity associated with higher antibody concentration and lowest rates of seroconversion infliximab combined with an immunomodulator, azathioprine or methotrexate. But the interesting part is the next part, that is, after 2 vaccine doses, the picture appears much rosier. Single dose of either vaccine, antibody concentration is higher in patients with prior SARS infection with single dose or after 2 doses of the vaccine. However, there remains a small percentage, around 18% of infliximab treated patients and 5% of vedolizumab treated patients who fail to seroconvert. So response to vaccination appears to be lower in IBD patients who are on immunosuppressants. And the message, patients on anti-TNF drugs or other immunosuppressants should be considered a priority for the second vaccination. Which is the preferred one? I think we have Covishield and Covaxin that is available to us. And we would say vaccines work. Anyone can be used. Vaccination is a priority for all patients with IBD. The immune response may be poor, but it's still, and the second dose should be a priority as well. We at the IBD Emerging Nations Consortium actually have taken out the position statement for vaccination in this part of the world. IBD patients greater than 16 years of age should be vaccinated for COVID-19, irrespective of the severity of disease. Immunosuppression is not a contraindication for vaccination, though immunosuppression, as we just discussed, may reduce the immune response. All vaccine types appear to be suitable and can be decided on basis of availability and local regulatory approval. Again, IBD patients on immunomodulators have suboptimal antibody response, and 2 doses of vaccine lead to seroconversion in most patients. So as a priority, the second dose should be given. Having said that, we are all dealing with the COVID pandemic. And as you can see, this is our team at AIG Hospitals, Hyderabad, all masked through the year as per COVID protocol. Thank you.
Thank you, Dr. Rupa. We'll have the questions at the end of the session. And so far we have had 4 beautiful talks. First one dealing with the pathophysiology, and third covering the entire immunosuppressed patient groups in gastroenterology and hepatology. And for the last talk, we have a very accomplished speaker, Dr. Anurag Agarwal, who is the director of IGIB, which is a CSIR institution in New Delhi. He is the recipient of the prestigious Shanti Sharoop Bhatnagar Award. And without wasting much time, I would invite him to deliver his talk on limitations of current vaccination and future perspectives. Dr. Anurag, please.
Thank you very much for having me here. And I guess thank you all even more for being here on a Sunday evening. So I'll talk to you regarding limitations of current vaccination and future perspectives. I would like to start where the last talk ended. Take any of the vaccinations available. They work. Let's get there. Okay. This picture is from more than 100 years ago, not from the current pandemic, but from the previous one. The Spanish flu, which covered all over the world and even went to Japan. So some ways you can think about it, the more things change, the more they remain the same. And let's talk about how vaccines might actually make a difference. I wanted to show you this slide before I go on to the benefits of vaccines to illustrate something. Immunity is a two-edged sword. What you see here is a Spanish flu data. You can see that after age adjustment, it's not only the very young who are likely to die, it was also the young adults. And many people have thought about many possible factors, not the elderly, not after adjusting. And one of the reasons was that there was another type of flu, somewhat related but not very related, sufficiently different, that these people who would have been in around the age of 20 to 40 would have had antibodies to a type of flu that were given them poor quality neutralization and perhaps worsening of disease. Now, this is important. This is important because you all must have heard so much about this topic, antibody-dependent enhancement. It occurs by one of two pathways. You have a non-neutralizing antibody, it binds to the virus. The virus actually gets efficiency in entering a macrophage. It only applies to a macrophage tropic virus. Inside the macrophage, it can replicate easily, and you're actually fostering viral replication. In the other one, and this was alluded to by Dr. Arora, you get immune complex formation. Sub-neutralizing levels of antibodies are the most common way. And this is relevant for respiratory viruses like RSV and measles. And you can get immune cell recruitment, complement cascade activation, and a huge amount of inflammation in the lungs. Now, at least the first of them can be tested in vitro, and we know the risk is extremely low for SARS-CoV-2. In the second one, sub-neutralizing levels, we have not seen any evidence so far, but it's good to be aware. Why is it good to be aware? Because we have seen a huge amount of pushback against vaccination, and facts remain the only way to combat the distrust of vaccines that has emerged at a level I must have said I would not have anticipated. Another thing that people talk about beyond the types of immunity Dr. Arora covered, active and passive and humoral and cellular, is herd immunity. Many people have had a plan of getting to herd immunity. Well, that's not worked out for at least two places that we know. One is Delhi, one is Manaus in Brazil. Both had achieved over 50% seropositivity, but in each of these you can see a variant came that overcame whatever barriers natural infection immunity had created, and they had an even more severe wave. And we've all lived through it here in Delhi. I don't need to tell you more about that. So in this context, we are in a new era of vaccines, one of effective vaccines developed very fast. If you look at the time in which a pathogen was linked to disease and the year in which a vaccine was licensed, this one is specific to the United States, you can see that SARS-CoV-2 has been an immense exception on the scale of things. There are fundamentally 6 platforms. Let's talk about a few of them. Inactivated viruses, we all know, that's coaxin. VLPs and recombinant DNA will come to later. Vector-based vaccines contain typically the DNA inside a vector. The vector takes the DNA to a cell. The cell makes the protein generates the immunity. And you had a very nice talk by Dr. Arora on how Covishield works. Then there are genuine DNA vaccines without a vector. I will give you an example of one of them towards the end. And the last category, perhaps one of the most powerful ones this time around, are the RNA vaccines, in which RNA containing the instructions to make the protein is enclosed inside nanoparticles, typically lipid nanoparticles, and they can directly go to human cells and ask them to make the protein. So what are the limitations? Let's start with the mRNA. It was the first one to be made. You are basically packing the RNA inside a lipid vesicle, and you're injecting it. It will basically go to any tissue it encounters where it can go. The heart seems to account for a good amount of the uptake, and which means the viral protein expressed by human tissue may lead to immune reactions to that tissue. And you've all heard about recent concerns by FDA regarding myocarditis. Again, very rare, not a major concern, but logical. There has been some very nice new discoveries in biology showing that RNA can be converted to DNA inside cells. This is something very new. So it brings us to possible limitations of DNA vectors. I'm covering DNA vectors here because that's basically Covishield for us, or Sputnik for that matter, or even J&J. The vector itself, being a virus, may induce aberrant immune response. I don't think we need to worry too much about reports about the vector being replication competent, the way Brazil authority reported for Gamaleya. The bigger problem with these is that you develop the antibody to the vector and you cannot use that vector a second time. So Covishield got over this problem by trying to increase the gap between doses, letting the immune response settle down, but that has its own challenges. Gamaleya got over this problem by using 2 different vectors for 2 different doses. And Johnson & Johnson got over the problem by simply having 1 dose. For those of you who may not know, even the plan for Oxford was to create a single dose vaccine. Now, whenever you're dealing with DNA, there is a theoretical possibility of DNA integration. It's extremely low frequency. Now, both mRNA and DNA vaccines, by making the human cell express the protein, induce strong responses, including strong cell-mediated immunity. That is the only problem with inactivated vaccines. They are safer probably, but they have weaker immunogenicity. 1 dose of a killed virus barely induces conversion. 2 doses is probably enough. 3 might be required to really get it going. The problem then of inactivated viruses that all of these mRNA and DNA are against the spike protein. That's the part that leads to neutralizing antibodies. When you give inactivated virus, you're going to make antibodies to the non-spike part of the virus. In theory, that could fall in the category of non-neutralizing antibodies that could lead to ADE, but that has not been seen yet. And we have plenty of experience by now. If we haven't seen it, either it's not there or it is extremely small. If it's extremely small, it's the same level of problem as the other problems of the other vaccines. The real practical problem is it's a very inflexible pathway. You have to culture the virus inactivated in large quantities, and this is slow compared to making mRNA or DNA vaccines. Pretty much, Moderna made its vaccine in less than a month. I'll come to exact numbers later on. So in India, we have obviously 3 vaccines currently available, and I don't think I need to tell anybody in this room about it. One of the obvious problems that you all know about is the efficacy is far from ideal. Sputnik has a reported efficacy of 91%, better than the others. But then the samples in that size of the study was quite small, so I would not take it as 91% yet. And anyway, as you know, in India, we'll come to the variant part later. We now have the Delta variant, which will reduce immune efficacy. So where are we going? Variants, vaccines yet to come, questions on durations of protection, questions about mixing and matching. I think that's a really interesting one. Vaccine hesitancy, usually to do with ADE, especially after that video went viral with a Nobel laureate speaking about antibody-dependent enhancement. And the known unknowns, and of course, for all of us, the unknown unknowns. Variants, I will cover it really fast. They are very common. Every time my institute sequences a batch from a state, we see hundreds of mutations. Most of them simply do not matter. But once in a while, given time, the mutation changes the behavior. And what I would show you is a figure. This is for Delhi, actually. What you can see is that light purple variant towards the end. That's the Delta variant, B.1.617.2. And you can see it went from almost nothing in March to pretty much 70% in May, April, May. It displaced one of the most transmissible variants in the world, the alpha, B.1.1.7. It is clearly more transmissible and has more immune escape. I can always talk about that later if somebody wants. So viruses evolved to become more transmissible. Viruses evolved to escape immune antibody responses. They will do it. Any vaccine you do, even if you don't give vaccine, you simply develop natural immunity. They will still do it. Not giving vaccines is not a sensible strategy to prevent viral evolution. In fact, when you give vaccines, you get less viral transmission. When you get less viral transmissions, you get less infections. When you get less infections, you get less chances for the virus to mutate. Nowhere in any part of the world, high levels of vaccination have actually been associated with rapid formation of variants. It's primarily been uncontrolled spread of the virus, and 1 dose, of course, may not be sufficient in the current forms like Delta, and already Moderna is coming out with new versions for some of its vaccines. The second possibility, of course, is that viruses evolved to become more lethal. That's a very unlikely scenario. Is it impossible? No. Is it likely? Not so. So a lot of concern today about the viruses evolving to, because of the vaccine, to have creating a third wave where babies will be involved. Most of it is poppycock. So vaccines yet to come, those in clinical development, those in preclinical development, and the future, which is the 100-day vaccine. Here is a pure DNA vaccine, which basically does not require a vector, and it's based on a spike protein encoded on a plasmid, subcutaneous injection, currently in phase 3. Very, very promising. Let's see how it goes. Protein subunit vaccines took a little bit longer to prepare compared to mRNA vaccines. So you've heard about Biological E with Baylor College of Medicine. It basically contains relevant proteins only and their subunits. Results are expected in August. Phase 3 is going on right now. Looks very effective in early studies. This is the Indian version of mRNA vaccines by Genova. It's a self-amplifying RNA. It's in very novel nanoparticles. Animal studies, including primates, is completed. Phase 1 is ongoing. You wouldn't expect this to become available before much later, maybe the third quarter of the year, maybe even later than that. Manufacturing is still being established. The difference here and the others is the RNA is built in such a way it amplifies itself. So you can use a very small amount of RNA, which means for a given production capacity of high quality RNA safe for human use, you can make far more doses for people. So if it works, I think it's going to be a game-changing development. This is a fact that I think you might find interesting. The design of the Moderna vaccine was 2 days. The production was 6 weeks. Pretty much the vaccine that went on trial in March 2020 is the version that you're using now. With this kind of a flexibility, you could continuously make variations upon the original vaccine as new variants come along. But the questions are complicated. Every time you create a new version, will you do a full trial? Will you again do a safety? Will you again do a 20,000 people trial? If you do that, then really what's the point of a 100-day vaccine? And if you don't do that, do we fully understand the risks? I don't pretend to give you the answers today, but these are the things to think about. And eventually one would imagine that for every virus, every mutant of the virus, we could have very, very specifically targeted vaccines. I'm going to end here. Thank you all very much. I do think COVID-19 will change the way we approach science and health. Thank you.
Thank you, Anurag. I think we are now at the Q&A session, even though we are running behind time. But I think before that, it's probably time for necessary. Anil.
Ashish, yeah, you can start.
So again, good evening, ladies and gentlemen. On behalf of Sir Gangaram Hospital and Delhi Liver Foundation, this now is the time for the felicitation ceremony. So after the academic feast of lectures and discussion on COVID, immune response and vaccination, we would like to felicitate one of the stalwarts gastroenterologists in India. As you all know that from last 3 years, the Delhi Liver Foundation, in the memory of Dr. S.K. Sama, has been recognizing and felicitating senior gastroenterologists who have made significant contributions in GI and liver field in India and who have dedicated their life in improving the GI and liver health of Indians. Today, the gastroenterological expertise in India is one of the best in the world, be it any field of GI specialty like hepatology, luminal gastroenterology, pancreatobiliary specialty, or therapeutic endoscopy. Indian gastroenterologists have made remarkable contributions all over the world, and they have produced path-breaking research and remarkable innovations in hepatology, gastroenterology, as well as in endoscopic techniques. Today, we would like to honor Dr. S.K. Sareen, who we all know as a teacher of teachers and teacher par excellence and one of the best hepatologists not only in India, but all over the world. But before that, I would like to pay my tributes to Dr. S.K. Sama, on whose memory we have instituted this award. So I would like to give a brief presentation on Dr. S.K. Sama and would like to share my screen now. So Dr. Sama, our tribute, he was born in 1934 at Firozpur. His schooling was in Himachal Pradesh, and then he did his medical schooling from Amritsar, did his MD medicine from AIMS, and also received his WHO fellowship in gastroenterology from Tufts University, Boston. He had a brilliant career by joining his alma mater at AIMS. He stayed at AIMS till 1974, during which time he established the Department of Gastroenterology at the AIMS as well as at the GB Pant Hospital. Then he joined Sir Gangaram Hospital in 1976 as the honorary physician of the gastroenterology and served the hospital for 36 years, including as its chairman from 1995 to 2006. While continuing his association with Sir Gangaram Hospital, he founded the multi-specialty Sama Hospital as well in 1982. And he has been a personal physician to the President of India in 2001. At Sir Gangaram Hospital, he founded the gastroenterology department, which has now grown to become a center of excellence. He held various posts at Sir Gangaram Hospital, including that of founder member of the board of management, and was also one of the members of its board of trustees. He became the chairman of board of management in 1995, which he continued till 2006. He was a teacher par excellence, and his devotion to academic field remains till his last breath. And he was a role model for many medical students and budding gastroenterologists. He was a keen researcher. He was a pioneer in medical research on liver disease in India. He published 51 high impact articles in various national and international journals. His 1962 article is reported to be the first attempt at describing the non-cirrhotic portal fibrosis. He is also credited with significant research on hepatitis B, and he'd always been inquisitive and had a zeal to learn the latest techniques in gastroenterology. His contributions to medical societies had been immense. He was a former president and life member of Indian Society of Gastroenterology, had organized 6 therapeutic endoscopic workshops. He was a life member of Indian Society of Study of Liver Disease, Indian Society of Gastrointestinal and Endoscopy, American Gastroenterology Association, and the Association of Physicians of India. He was president of the New Delhi chapter of the Indian Medical Association. He was a board of advisors of the American Hospital Management Company. He had received multiple awards. The government of India had awarded him Padma Shri in 2004 for his pioneering research on liver disease, including NCPF and hepatitis B. He received the highest Indian medical award of Dr. B.C. Roy in 2004. He was also recipient of several other awards such as Punjab Ratan Award, DMA Ratan Award, Bharat Jyoti Award, Bhaskar Award, Human Care Award, and Delhi Ratan Award. And he had delivered several award lectures such as Presidential Oration, B.L. Kapoor Memorial Oration, Dr. K.L. Vig Memorial Oration, and R.S. Tiwari Oration. So he was known as father of gastroenterology, teacher of teachers, astute physician, able administrator, and our heartfelt tribute to him. With this, now I would like to hand over to Dr. Saurav, who would read a citation about Dr. S.K. Sareen, who is the present recipient of this Dr. S.K. Sama Memorial Award. Dr. Saurav, please.
Hi, good evening, everyone. Thank you so much. I will, I guess I can also share the screen here if you guys allow me. Hopefully this is visible. Okay, so it gives me immense pleasure to introduce Dr. Professor Shiv Kumar Sareen. It's truly an honor. Professor Shiv Kumar Sareen is a senior professor of hepatology and director of the Institute of Liver and Biliary Sciences in New Delhi. He was instrumental in setting up the Institute of Liver and Biliary Sciences under the auspice of the government of Delhi. He's also the director, WHO Collaborative Center on Chronic Liver Disease and Viral Hepatitis at ILBS. He serves as an adjunct faculty, molecular medicine at JNU due to his deep interest and contributions to translational science. Professor Sareen has more than 650 publications to his credit, edited 13 books on liver diseases, and has helped develop 19 major guidelines. Professor Sareen has also shown leadership role in being the president of the Asian Pacific Association for the Study of the Liver He's a recipient of Shanti Swarup Bhatnagar Award, prestigious Henry L. Baucus Gold Medal in 2017 by the World Gastroenterology Organization, the World Academy of Medical Sciences International Prize, Easel International Recognition Award. He has been bestowed with Padma Bhushan by the Government of India. He's the founding chief editor for Hepatology International. So thank you. And
Dr. Arora, would you like to say a few words?
I think after listening to the presentation by Dr. Saurabh, speaking about contribution of Dr. Serene to hepatology is like my showing lantern to the sun. Before I step in, I would like to see Dr. Serene trying to recall his journey of hepatology and his contribution to field of hepatology. Let me also remind that both Dr. Guru Iqbal and Dr. Serene used to be present at All India Institute of Medical Sciences as his students when Dr. Sama was a faculty member and would have been the next head after Dr. B.N. Tandon. But tribute to his forevision that he left All India Institute of Medical Sciences in 1980s at a time when nobody would have even thought of leaving the premier academic institution. He had a forevision of establishing the same quality of academic and research in the private sector, which has borne the fruit of the day. I request Dr. Serene to tell us about his experience of AIMS and development of hepatology.
So you're muted. Dr. Serene, you're muted.
Thank you all. And I know it's a late hour and the evening after very, very nice lectures. I really enjoyed. I missed Dr. Arora's very excellent talk and Dr. Gautam's talks. I just heard the last slide, but the next 4 talks, fabulous. So congratulations for conceiving and making this great and timely review. Before I just go on to the journey, I would like to add to one thing what Dr. Anurag said. The very recent paper in Cell, which gives a single cell, multi-omics approach, which opened our mind, at least my mind, why you have day 17 to 30, the second wave of immune, and the important cells are your PDCs, plasma cytoid dendritic cells, and NK cells, and IL-15. I read it, I realized how little we know about COVID. And also that why patients have a digression at day 21, who will die, who will survive. This is just to add to the excitement that I had when I heard these great talks. And just to cap on to what he very politely said, the inefficacy, not inefficacy, difficulties of the variants and the vaccines coming, and where can we go? So this puts us all in a entirely different league. Anurag, I didn't want to kind of say that what you said was less, but what you said stimulated me to say, and I enjoyed every single talk. My journey has been of luck, more of having good friends. I remember a few things about Dr. Sama I'll come to, but when I was working at AIMS, and this may be known to very, very few, I was very excited with hemodynamics from day one. And when I was given an opportunity to go to GB Pant, Dr. Chutani was the chief. And he actually dropped into my F-32 house and said, "Wait, तेरे को लेके जाना है मैंने." I said, मेरी एक ही कंडीशन है सर, मुझे थोड़ा सा कार्डियोलॉजी का सपोर्ट मिल जाए. तो उस समय डॉक्टर खलीलुल्लाह was the cardiology chief. So Dr. Chutani drove me in the car. This is a 5 CR, 5 crore machine, the best cardiology. मैंने तेरे को 2 दिन देने हैं, तू 2 दिन इसमें काम कर ले. I said, yeah, this is like a dream. I mean, you will get 2 days of hemodynamics and all that. And he, one of the best guys, H.K. Chutani, who could, motivate. And he was also instrumental in many ways in telling me every other day, "Bhai, tu kya kar raha hai? Kuch kar to sahi." And that is one of the things that I think a mentor or a guide or a philosopher can do. I would like to just say that I had very good friends. Uh, I had very good mentor. I learned in AIMS the precision in time and the value of never saying die. And the discipline that I learned was huge. And one of the mentors is still in Gangaram, that Dr. Nandi. Just to share a story, I was one of the thesis with him, third thesis other than that. And I was supposed to be with him at 2. And if you're not there at 5 to 2, you're dead. And every single pro forma, what I would fill, those days you have to have a carbon copy. So one copy is deposited with him and one copy. So you can't mess up. My next big teacher was Roberto Grossman when I reached Yale. And I was lucky to get the lowest marks in the NIH ranking. The lower, the better. So I could choose to work with Roberto. So when I joined, I had a few papers in gut, but whenever I would present something, I would say, yeah, I'm lucky. Roberto said, no, don't ever say lucky. Say, you must say that you did the work. So how I did the work, and it's interesting because it changed my approach. I had never worked on a mouse, 20-gram mouse, and I was to develop the hemodynamics for mouse, the liver hemodynamics. And Roberto was a hybrid of cardiology and gastroenterology. So I started, and he thought there was no hemodynamics ever done for liver in mouse. So when I started, he would come and stand behind the door and watch me, what this guy is doing every single time. So I would actually learn and finish in about 2 weeks to cannulate and get the hemodynamics, double microsphere and all that. He was happy. I did about 300 animals in about 4 months' time, and each mouse was $8. And every tracing was put into his cabin, polygraph 7. After I finished 4 months, I was happy. My paper was ready for JCI. This guy tells me, you have to repeat everything. I said, look, I'm here on a Fogarty for 1 year. He says, you repeat everything. And every time I did 300 first time, and I had to do about 750 animals next time. I did it in now 2 months. Then he taught me what I want to share is science has to be reproduced. And do only what others have not done. So just want to share my journey. Many, many things I have learned. I won't take others' time. And what I've said is spontaneous. I didn't plan to speak. But just to say that some people can make difference in your life. I had known Anil for long. I mean, if he had not been in practice, what would have happened? This brilliant guy would have made entirely different. Ashish has worked with me. I always miss him, but he doesn't want to kind of oblige me with more of his excellence. I haven't worked with many. With these thoughts, I would just like to say 1 or 2 things about Dr. Sama. When he was the chair, I had gone to meet him for some patient or so. I just asked him, sir, किस तरह चल रहा है? बढ़िया चल रहा है. ऐसा बढ़िया दा की मतलब? यार, we are making profit. I said, sir, उसको पैसा बना के की करना है? बोले, यार, I will reinvest. मैंने नहीं पता what is reinvest. बोले, यार, तेनू पता नहीं है, तू तो खोता है. And actually, he sat down half an hour on coffee and told me some of the best management things. Of course, he was a great gastroenterologist. I'll not take more time, but just to say, some of his words, especially saying "tu to khota hai," like in management, I was a bluffer. I do not know whether I made any difference. but he taught me something. Adda kaam kar, adda plan kar. And some of these things have remained with me. I had the pleasure of going with him on several international trips. He used to, kind of share all kinds of things. And my interest remains that, well, I have my fellows better than me. Each one of them should outsmart me. This is all what I will say. With all humility, I am part of this journey with you all. Thank you for making me and having me this special honor in name of Professor Sama. Thank you.
Thank you, Dr.
Thank
Serene. And Dr. Arora, would you like to say?
Thank you, Dr. Serene, for having honored us by receiving this medal. And we are happy to know so many aspects of your journey through gastroenterology, which was naive for us as your student also. We didn't know the type of exposure you have had with Roberto Grossman in jail and the type of hard work you do. We certainly knew the outcome, but we didn't know the basis of your success that you have revealed today. Thank you so much for accepting this honor. Now we, being a e-format, I think somebody went to deliver the medal and shawl to you yesterday. You were stuck up in a meeting. They'll come back and deliver it to you at home. With that, we'll come back to the academic program. May I hand over the dais back to the moderators and chairperson to take over the question answer session.
Piyush, you can start.
Yeah, I can't see any questions in the chat box or in the Q&A section. So let me start by asking a question, and one of the speakers can answer this. So we have been talking about this, the measurable success of vaccination is the antibody level. And going by the entire immune response, and Dr. Mohandas mentioned this, that cell-mediated immunity might be playing an important role in the protection. So is the antibody titer the best way to predict the success? We know that these are early days, then we don't have the clinical data of efficacy of prevention of serious infections after this vaccine in this immunocompromised group. So what are your thoughts on this? The clinical efficacy of vaccine in this immunocompromised patients? We don't have enough data. We have only serological data that it produces antibodies to a certain level. What happens to the prevention of serious infections, reinfections? And what are the ways of measuring other than antibody titers? What are the other ways of measuring the protection provided by these vaccines? While we await the other questions from participants, we can start.
Dr. Anurag, to put it in other words, is there a way of estimating the T-cell mediated immunity? Because as Dr. Mohandas said, even though the antibody levels may not be sufficient, but clinical endpoints in terms of reduction of the mortality, need for hospitalization is much less, even in patients with cancer and organ transplantation after vaccination.
So let's break this question into three parts. Number one, antibodies by themselves. So absolute antibody levels do not correlate well with the immune ability. It's the neutralizing antibodies that correlate well. There was a nice Nature Medicine paper recently. Number two, they looked at for asymptomatic course and protection from severe disease, the ratio of S2N antibodies. That's again only relevant for other vaccines. Now, number three part comes, how would you measure neutralizing antibodies and how would you measure CMI? So neutralizing antibodies have two methods. One are called surrogate virus neutralization test called SVNTs. There is only one on the market called CPAS by GenScript. It basically uses synthetic RBD domain spike protein with the ACE2 receptor, and you look at binding inhibition. The other ones require you to have a viral culture lab and do in vitro neutralization assays. If you wanted to measure cell-mediated immunity, you have to isolate PBMCs and you expose them to viral antigen and you look at the cell proliferation response. To be very honest, there have been no good studies currently published showing that the presence of such a response is a good indicator of protection against disease. In fact, there's 20 to 30% cross-reactivity in people who have never had SARS-CoV-2. So while it is very interesting, it is still research grade level. In actual clinical practice, the best you can do is neutralizing antibodies using the CPAS gen script. That's what I'm aware of. But our research work certainly is measuring CMI.
Can I ask Dr. Anurag? Dr. Anurag, the basic problem in COVID-19 is the failure of the initial interferon response, type 1 interferon response to the incoming virus. And suddenly we take a U-turn and say that there is people die of hyperimmune response. So why this dichotomy?
So your first statement about the primary problem being failure of interferon comes, I think, from three observations. Number one, the JIVA study that was carried out in Spain, targeting the interferon genes. Then the family with multiple interferon production deficient people that basically showed that these people had more severe disease. And third, transcriptional assays showing that interferon response is on the average inhibited in people with a more severe course of illness. And of course, you could be also talking about the interferon treatments that people have shown reduced severity. But if you look at all of them, neither have the interferon treatments been spectacular, nor has the data been so clean in any of the first three papers I referred to that we can say that is the problem. It is one of the things that we see. It is certainly not the only thing that we see. In a large number of people, the problem starts much later after virus has been cleared. And at least in those people, in your own talk, you had that slide about aberrant inflammation starting much later. And what Sareen was alluding to the single cell genomics paper that came out recently, talking again about one level was T cell exhaustion, other was a complete changes to the immune system that occur over the course of illness. I think it's too early to say it's interferon failure. I think what we are seeing is a mixture of many things that presents clinically very heterogeneously. Some people fall in the category that you talked about. They typically worsen early and they do poorly. But there are many people who worsen late, which are not in that category. I'm sorry, I've not actually answered your question, but just kind of expanded upon, it is not just an interferon problem.
Okay. I had a question, if I can, Dr. Arora.
Yeah, Saurabh, go ahead. Yeah.
So we've seen we've seen individuals having systemic inflammatory response syndrome for about 24 hours to 48 hours after getting the Covishield vaccine. Now, in patients with decomp cirrhosis, I've heard of patients getting encephalopathy as well, requiring admission. I haven't heard of any mortality post-vaccination. But I was just wondering if Dr. Mehta has any thoughts on this, or any of the other panelists, or speakers rather. Have you ever seen this? Or
Gautam, are you there?
Yeah, I'm here. Can you hear me?
Yeah.
Yeah. Hi. So you're quite right to wonder about safety in these populations. They're obviously quite vulnerable. I haven't seen problems of decompensation of liver disease with these vaccines. I've seen two, and of course we don't have systematically collected data yet, which is what these registries will provide. But of course, I suppose the first thing is that PF4 antibody-mediated thrombosis to the Oxford AstraZeneca or Johnson & Johnson has been described as very rare, of course, but the most common site is cerebral. So cerebral sinus is the most common. The second most common is splanchnic in those populations. And we have seen a cirrhotic patient with splanchnic thrombosis having complications following vaccination. But of course, the absolute numbers are very, very low. And this is obviously not related to underlying thrombogenicity. This is an immune-mediated phenomenon. So I think that's one problem, though, that I think we'll need to see whether the incidence is higher in cirrhotics or not. And I've seen one person post-liver transplant with acute cellular rejection following an mRNA vaccine as well. And anecdotally, these are both things that I've heard of from colleagues in the area. But that's really all I can say without access to registry data.
Okay.
Yeah, I think I would like to also take you a little away from the nitty-gritty to a slightly different perspective of the extent of the problem. if we look at what has happened over the last year and a half, some 175 million people worldwide have been affected by COVID-19 till June 11. It is estimated that some 115,000 healthcare workers have paid the ultimate price in the service of others in the last 18 months worldwide. If we are to reach where we want to reach to prevent a third wave, which currently seems imminent, at least in the poorer countries, and also in some other countries in the developed world. That means by September 2021, worldwide, we need to vaccinate some 250 million people in low and middle income countries in the next 4 months. And that is a humongous challenge. And in that, we, the healthcare workers, and of course, the most at-risk groups are the first priority. Today, we are talking of one category of people at risk. In poor countries, the poor themselves, by their very poverty, are at greater risk. The only saving grace is that all studies in the last few years in poor countries like India have shown that our overall age standardized incidence of the most common cancers, except breast cancer, has remained static over the past 2.5 decades. Except for breast cancer, where we don't know why it's going the way it's going. Now, as Dr. Rupa Banerjee had pointed out, access to care in rural areas is a huge challenge in countries like ours. Availability of vaccine is a huge challenge even in urban areas for the present, and much greater in the rural area. And in addition, there is the issue of vaccine hesitancy. So we are actually at the population level looking at a number of challenges which are as grave, as serious as the virus itself, and therefore understanding the mechanism of how it works and what it does and what it doesn't do. I think are two sides of the coin which probably both need to be dealt with. And I think while there is hope expressed at the beginning that this hopefully would be the last such webinar that is being organized, but I think there are many other perspectives and perhaps many other challenges. And I think I'm more with Anurag on this, that there is a much greater likelihood of a third wave with at best an interregnum of only 2 to 3 months. So any thoughts on my thinking? Any comments on my thinking?
I have a okay.
Mohan, you can go ahead. Yeah.
Okay, I have a general comment, and that is, just because we can't vaccinate all our people doesn't mean we should not focus on our patients and their families in the immediate environment. They are at high risk. For me, all my patients are at high risk. And for, I think, most panelists who are hepatologists or gastroenterologists, they have patients who are on immunosuppression, and they're all at high risk. So as a small step, I think our societies need to come forward and help these patients get the vaccine, which is the biggest challenge. The challenge is trying to make vaccine available easily to the patients, which has been, like in my hospital, we had to supply for some time and then there was no supply. So, patients who are advised to go elsewhere, they said the queues are long and we are scared we may catch the infection while standing in the queue. So there has to be a mechanism by which India has about 5 million cancer patients, and if you add their family members, and if you take all patients who are on immunosuppressive therapy in India, I'm sure there are at least 50 million Indians who will need, and their family members who need vaccination as a priority, just like we vaccinated the frontline workers and the elderly. On the same footing, we need to go ahead and do that.
Dr. Anurag and Dr. Gautam, can we think of adding in these immunocompromised patients a third dose of vaccine? I mean, giving an early third dose of vaccine rather than waiting. A third dose of vaccine has been in pipeline. So adding one more vaccine maybe sooner, does it help immunogenicity in these group of patients?
So you would have to think about which vaccine, and that's where the mix and match idea was coming from. Some of the vector vaccines will work less and less every time you use them. Okay. So clearly a third dose of Covishield would not be a very successful one. Now Covishield followed by Covaxin might be a reasonable idea. Covishield followed by Sputnik might be an interesting idea. But yes, I mean, I will leave it there. The rest is for my distinguished clinical colleagues to judge. But you'd have to think about these scientific issues in doing this mix and match.
It's I think it's inevitable this is going to happen, but of course it requires these considerations to be taken on board. In France already, they've started using a third dose of the same previous dose, that's previous brand that's been used for solid organ transplant recipients. That's in the last 2 weeks. That is already starting. That is obviously outside the regulatory approvals, at least in other countries. France have pushed this through unilaterally because none of the trials that are published so far use a third dose. Pfizer are starting a phase 2 embedded study in Germany of a third dose, again in immunocompromised individuals. So we'll know a lot more in the coming months. So I think it's very likely that this will be where we go. To do a regulated trial of a mix and match regimen, I think will be very difficult given where we are with the companies. But I think, for example, Pfizer RNA vaccine are doing a third dose, and that will probably be the first clinical trial data we will see in the next 6 months or so.
Yeah, Dr. Anurag, can I ask you a basic question? When it is a question of mixing and matching, do you think it is a necessity because of the force of the circumstances that you do not have enough vaccine on board, or does it relate to the science? Because every time you mix and match, you're giving different antigen that will go again through a different process of adjuvant related primary immune response, then generation of the secondary type of memory cells. Antigens may not be the same. So what is the science behind mixing, unless you are forced to do it? Because just like in India, you have too much of Covishield and not much of Covaxin. So you are forced to do it.
No, so there is a scientific logic to it. In particular, it's there for the viral vectors. Every time you use a vector, next time you use the vector, the ability of the vector to deliver is less. The problem does not exist for mRNA vaccines, but as of now, India has no mRNA vaccines. So a third dose of Pfizer, or now, for example, Moderna, has already come out with a South African variant specific version. So the third dose actually for Moderna people will be with that particular version. A killed virus could certainly be given a third time, but again, the problem with killed virus vaccines is immunogenicity is low, and because no living cell picks up the virus easily and displays it on the surface, CMI tends to be low. And then there have been concerns, like I said, about AD, so you don't want to do that. So mix and match, where mRNA vaccines do not exist, will clearly have a scientific basis in a combination of vector and killed. Now, clearly, once you have the 3 vaccines I talked about in India, one is a pure DNA vaccine using a plasmid delivery system. Perhaps you would not have to worry about it. Other, of course, is the self-amplifying RNA vaccines. And of course, we all do wonder when the mRNA vaccines would become available for use within India. But so it's a little bit of science, given the choices we have, and a little bit of compulsion, given we don't have some others, where we could simply do flexible mRNA platforms.
Is it again because of the pandemic situation, or do we have any parallel example in the history of vaccination to mix and match?
That's an interesting point. So we don't have any clear examples, but to be very honest, when have we ever had any real DNA vector vaccines in humans, or mRNA for that matter? So these are all first time in human beings. Vector DNA vaccines were used in animals, but then nobody holds them as precious as humans. So nobody really bothered. And like I said, I mean, so it's a unique situation where you have platforms which are not reusable n number of times with the similar efficacy every time you give it. And remember, ultimately, you expect many vaccines to be given by vectors. For example, you might even have DNA vaccines for cancer. So every time you use up a vector, you're closing off directions for that vector for other treatments in the future. So you don't want to be cavalier about using too many vectors.
So I just had a point. So now we are discussing all the vaccinations, and we've had our second wave, which was massive. We were discussing before the webinar started, Dr. Agrawal. Now, I wonder, I know in your estimates, the seroprevalence has gone up significantly in the population. We don't have studies, of course, but I was guesstimating based on the Nagpur population, the number of cases that we've had and how many were not diagnosed, probably looking at 50% seroprevalence rate or 60% at the lower end just after these two waves. Now, I don't know if there's another variant that comes across and then we are again, I don't know how that will impact. But if with the 50 and 70% seroprevalence, we should be looking at herd immunity right now, isn't it?
So that's the example I was showing. So herd immunity makes two important assumptions. That people who have presence of antibodies actually are immune to the circulating variant of the virus. That assumption is simply not always true. Otherwise, we would not have flu anymore, for example. So what we see, and we have actually very good data. I mean, even for Nagpur, I'll have data within the end of this month, because the CSR labs have 10,000 people cohort across the country. So each of our lab is now starting to send in samples. The first run for my lab, and remember, usually I'm at the lower end. So when Delhi government said 56%, my lab was at 45%. So when my lab right now is at 80%, I don't know what Delhi government is going to find. So it could be a little bit of a bias, but like I said, even when I restrict my sample only to people who have been participant on all the previous phases of my sero survey, then the number comes down to only 76, 77, but still I'm looking at around 80%. But the point is, will these 80% remain highly immune to the next variant of the virus? You already heard about K417 mutation, K417N mutation coming on top of Delta. It's called the Everest mutation. It has been found in mountaineers. So we did the sequencing for Nepal actually. So Nepal is where this particular mutation is first seen. Now UK has a few cases. Also, US is also, it has reached. So K417 was first described along with N501Y in South Africa. If you all remember, AstraZeneca's efficacy in South Africa was 10 to 20%, right? Now N501Y is also present in B117, the UK variant. There its efficacy was 80%. So K417N could certainly be very important. E484K was the other one. And so we will find out very soon what happens, which is why we're going to come back to the point I think that Gautam was making, that at least for mRNA vaccines, and the point I was making in my 100-day vaccine strategy, as these variants develop, killed virus vaccines cannot keep up. It takes months and months and months to get into production again. Only things like mRNA or DNA vaccines will keep up. Within DNA vector vaccines cannot keep up. How many vectors will you make? So you would end up with very innovative delivery platforms for either DNA or mRNA. That's my best guess. Natural immunity will get you so far. It will buy you 6 months. It might buy you 8 months. And every time the disease might get milder. But it will not completely prevent outbreaks. No. Sorry for the long answer on that one.
Fascinating. Thank you.
Dr. Anurag, one important is if somebody wants to know what is the effect of vaccination, somebody gets 2 doses. What sort of antibody would you recommend? Would you recommend a total antibody or neutralizing antibody? And is there any correlation between neutralization, which you test in vitro, vis-a-vis its efficacy in vivo?
So let me answer that. So things I would tell people to order would be either quantitative, spike, RBD antibody. So Roche has one, Abbott has one that I know of, which are good. Or I would tell them to order a CPAS GenScript type of an assay. The correlation between the two is 0.92. So we have done, I think, thousands of them by now. The correlation between GenScript and actual live virus neutralization is also 0.9 plus. So what you could argue is an in vitro test without going to complicated labs, you have a 90% correlation of the test you're ordering with something of in vitro live virus neutralization, which has been shown to have good correlation with protection. So you got 3 correlations in the root. If you do only quantitative spike, you are 90% correlated to neutralization in vitro. If you do neutralization in vitro, which is more expensive, about 700 rupees, I think, Then you got 90% correlation to live virus neutralization. And then, of course, the last one of real clinical efficacy, there's a nice paper. But let me repeat just one last important thing. All these synthetic in vitro assays and even the live assays depend on which virus version you're using. As more and more variants start floating around, you need tests that are designed for the prevalent strains in your country. So far, they haven't come, but I expect it to be a matter of few months.
Dr. Nawaz, I have a couple of short questions. One
Sure.
is, we have so many reports of animals getting infected, particularly the zoo animals. So what about the extra human reservoir that's going to keep the virus as well as the mutations? And
you must have heard recently about dogs getting infected with the Delta and its parent Kappa variants.
Yeah.
So
the zoo animals, the lions, all the cats.
Yeah. So Lancome, the lab in Hyderabad that looks at these animals in the zoo, is actually my sister lab. So it's quite interesting. Definitely we are seeing it. There's a lot of similarity of the ACE2 receptor between us and many other mammals. So far it's been more in one direction, human to animals. There was this thing in minks that also came back, mink to human. But yes, I mean, it's just one of those realities. I don't think what we can do to stop it. Cats, dogs, minks, lions, I mean, the entire feline family. Keep your distance. I don't know what else to say. But yes.
But is it not paradoxical that usually the viruses do not jump the species? How is it that jumping it so fast? Is it because of the variants?
I think we have never before, at least in memorable history, ever had a virus infecting so many people, creating so many opportunities to mutate, and being tested so frequently ever. The resources, the world, I mean, if it was something else, we may not even have known that dogs and cats got infected. We have this huge capacity to test in the world today that simply hasn't been there earlier. And the number of cases, I mean, I don't think there's anything comparable in my life or in fact in recorded history.
You think it is a re-engineered virus?
What?
Retro-engineered virus from Wuhan?
I mean, so even the most conspiracy-minded come to not a artificially engineered, but a culture-evolved leak. So I don't see. So if you go back to the IIT Delhi paper that talks about the HIV sequences, that remains as invalid today as it was last year. They happen to be slightly validated by comments regarding the origin from the Wuhan lab. But there are very few traces of synthetic sequences in the virus, except for that one codon that people keep talking about. That codon occurs at 3% frequency in coronaviruses. As you know, our statistical tests give you a 5% probability of the results being false by chance, and you know they're very often false. So the point is not one direction of is 3% more probable. The question is creating a synthetic signature that none of us have picked on. Is that more probable or is 3% more probable? But I do believe that the possibility that people do talk about, they're collecting bat viruses and pangolin viruses and all those viruses and culturing them, and perhaps those cultured viruses having escaped, that's a possibility. How can you distinguish a cultured natural virus from a natural virus? You simply can't do it. So that will never be proven one way or the other because it will be a natural virus. But that's just my 2 cents. I'm not an expert on the matter. But yes, I mean, I do end up speaking on such issues often.
Anurag, let me ask you and Anil a question. We all know that cancer patients are more at risk when it comes to COVID-19. We also know that some cancers affect the B cells, particularly blood cancers, some of them. So when your white blood cell counts are down, then what should you do? Should you delay vaccination because your counts are down?
That's a good question. I'll let Anil take the hard part of the answer. I'll take you the easy part of the answer. We have a cohort of SCID kids in Kerala and across the country who have no B cells, right? And many of them have been infected with SARS-CoV-2 by now, and they've recovered quite fine. So, remember, when you talk about people dying, there are two types of people. People who are already at risk of dying get infected and die early. They are fundamentally at risk of dying. And then there are people with immune deficiencies, primarily like SCID, and they die because of immune deficiency. In our young kids cohort of SCID, we don't see very much. Now in cancer patients who are fundamentally sick and perhaps at high risk of dying and don't have B cells, that's not my domain, that's Anil's domain. I'll give it over to him.
Yeah, there are two aspects to your question, Dr. Gurukpal. One is that ultimately, once you have to get rid of the virus in the natural course of the events, you have to have both things. If you want to neutralize the infection, you need to have antibodies, which will try to cover up, especially if you have high affinity antibodies, so that the infection doesn't get settled down and the virus does not enter the cell. But once the virus has entered into the cell, the only way you can get rid of is by effector T cells, be it CD4 or CD8, depending upon what type of antigen is presented by the APC. So almost all mortality today is occurring because of the lack of the T cells, which are not able to clear the infected cells. As infected cells continue to proliferate, they will recruit more and more T17 cells, which will recruit pro-inflammatories like neutrophils, which will increase the mortality and kill the cells. More cells are killed, more cytokines are released. So it is a vicious cycle. So to have effective clearance of the infected cells, you need to have T cells. Now, if there is also contribution of the B cell in clearing the infected cell by something called ADE, but antibody-dependent enhancement of the toxicity. But as of now, in COVID-19, in humans, there is no proof that AD is relevant.
Thank you. I have another question to Dr. Anurag. There is one researcher from, her name is Dr. Gandhi, who talks about low exposure, which can protect individuals. So, when you wear a PP, 95% protective compared to a 50%, you are eliminating all the exposure altogether. So do you think that after vaccination, if somebody continues to get low exposure, say through a surgical mask, they will be better protected in the long run as compared to someone who is, wearing a N99 or N95 mask?
It's a very intriguing thought. I don't know the answer, but yeah, I mean, you would imagine theoretically.
Because in practice we do that, we assume that people get in our practice and the antibodies go out.
So the masks as vaccines paper in the New England Journal was a very interesting one, and I kind of see the logic of it, that if you could control very low level exposure, then it might be good for you in the long term by getting a boost to you. But I don't know if anybody who's been brave enough to necessarily try it that way. But I do remember a discussion with Dr. Kang when she was pointing out that many people early on in the things were pointing out that lab people with very low level exposures while wearing masks, etc., were showing antibodies. So yeah, maybe what you're saying is true. I don't know. I would probably still say for doctors who are probably working in indoor, poorly ventilated, high aerosol areas, better stick with N95 and 99s. But even peppers if you have it, But what you're saying makes sense for people not at very high levels of exposure.
There's also an observational study that showed that the cancer patients who seroconvert actually have better control of the cancer as well. In other words, seroconversion of a cancer patient is an indirect indicator of that person's immune responses, not only to COVID, but also to cancer.
True. Could be.
That will also be corroborated by the fact, Dr. Anurag, you'll, I think, like to concur with me that, when the measles vaccine has been given in the general public, it has been shown that the mortality and the infection rate because of the different agents has also decreased. So once you have initiated vaccination in the general population, it tends to stimulate your innate immunity in general. So overall, the risk of infection because of the other agent decreases over and above the protection of a particular vaccine. The classical example was measles. Would you like to comment on that, Ranga?
No, you're right. I mean, many people have tried that route, haven't they? So people have tried the leprosy vaccine, the people have tried BCG, people have tried this. A general boost in the innate immunity, as you presented very nicely in the beginning, is one way to combat it. And pretty much anything that stimulates the innate immune system might make it better. And in fact, I will come back to my SCID example. So we know that SCID kids are at higher risk of death with any infection. And we found, at least with SARS-CoV-2 infection, it was no better, no worse. I mean, they are, of course, at higher risk as they are with any infection, but it didn't seem to be any particularly worse compared to anything else. So obviously their innate system is handling it. And results in India are somewhat better for these kids compared to really bubble kids growing up in a SCID bubble outside India. So you could argue those kids who make it in India to a higher age anyway have good innate immunity. That's how they have lived. We don't maintain the bubbles the way the West does. So it kind of goes back to what you are saying, that good innate immune system will compensate a lot in at least preventing severe disease and keeping people alive. And these alternative pathways like either measles or all these trials are ongoing. There is only in the end one way to answer these questions, which is do a high quality trial. UK seems to do most of them. So maybe Gautam knows if any good trial is happening in UK that we can wait for.
You know, what I don't know is if there's a good trial of an adjuvant with these vaccines. And you know, we know that, for example, hepatitis B vaccine, there's a recently licensed product with a nice adjuvant which is being trialed in cirrhotic patients in particular. So that I don't know. I don't know if you know, Dr. Anurag, but the Octave study that somebody mentioned is a very deep immunotyping study of responses in immunocompromised patients, cancer patients in particular, but other immunocompromised patients. That I think will show us a lot. The number quite small, but it's very deep immunophenotyping. So we'll learn a lot from that study. But I don't know what you think about adjuvants. I don't know about any trials looking at adjuvants in particular.
No, I'm not aware of pure adjuvants. I mean, one can think of many of these killed MW trials as almost like an adjuvant for the body.
Yeah, I guess it was sometimes these very selective TLR agonists too, right? So I think that might be interesting. CPG.
Yeah, CPGs.
I wonder whether anyone in this panel can throw some light on the issue of stem cell transplants or CAR T therapy in blood cancer patients, which is, I believe, coming to India soon. Tata Memorial and Reddy, some things, some trials. So, is it true that in these you can, if you are undergoing these, then you have to necessarily wait for some time before you can give the vaccination? If this therapy is being tried, you have to wait for 3 months. This is what the National Comprehensive Cancer Network recommends. Or is it alien to India yet?
Dr. Mohan, would you like to comment on that?
Yeah, I showed the NCCN guideline. So patients undergoing hematopoietic transplants as well as CAR T-cell therapies need to wait for at least 3 months before they can take the vaccine, simply because they will be, heavily immunosuppressed and they are unlikely to develop antibodies following the vaccine. As far as CAR T is concerned in India, last week the first case was done at GMH Mumbai along with IIT Mumbai. IIT has devised the CAR link and the patient was treated at the exact center of GMC Mumbai.
Are there any guidelines about someone undergoing major surgery? When
yes,
such a person
I actually showed you there was an NCCN guideline a table for various categories of patients. What is to be done for surgery, the vaccination should be carried out few days apart from the day of surgery. So it can be before, ideally, if not after. But not to do it on the day or the day just before the surgery.
Thank you very much, Dr. Mohan.
Okay, can I ask Dr. Rupa if she is still there? I can't see her on the... Rupa, are you still there? Is it possible to hold on to immunosuppressants like infliximab or adalimumab or steroids or isothioprin for some time, give vaccination, then restart, especially in a patient who is stable?
I would rather feel that we should, instead of stopping it and risking a flare, it may be worthwhile with the current data to go for the second dose a little earlier. Because the Clarity study is showing that with the second dose, optimal level of antibodies are being achieved in more than 80 to 90% of people. So in the situation, maybe rather than, hold it, it may be better to just give the second dose. So I would say that the current government guidelines of giving the second dose of Covishield after 3 months or, it will be better if we can give it at the standard of 4 to 6 weeks post the first dose.
What about patients with acute flare, Dr. Rupa? How much time should we wait for the flare to settle down?
When there is a flare, what we are doing it in practice right now is because now we've got a large pool of IBD patients who have developed COVID as well. So the IBD patients, around 94 patients that we have seen of IBD with COVID. Normally the picture, the pattern is same like the general population. But we have had 3 cases of Crohn's disease who developed thromboembolic complications with intestinal perforation. So I would normally therefore be wary of stopping medications and other things. So even if the patient is on flare, the standard guideline, what we do is go for the vaccination.
Right.
When you don't have it, you go for the vaccination. We tell them your antibody response may be poor, but still it will be better than no vaccination. And we would prioritize these patients for the second dose. In fact, we would, we actually put up the position statement that IBD patients, based on all the evidence available so far, should actually be given the second dose early. We are having such a nice discussion. I think the time is flying by. I've just been listening. I think Dr. Anurag is wonderful, and all of you. I think this is a really elite panel, and I must thank Dr. Arora for arranging this level of discussion. I think every point has been so valid.
So like Dr. Sareen said, he's lucky. I am more lucky than him. I have a galaxy of stars assisting me in good quality discussion. We have Dr. Mohan Das, Dr. Jaya, Dr. Anurag, Dr. Piyush, Dr. Solanki, and Dr. Gautam, Dr. Ashish. So I am the luckiest person. With that, do we have Dr. Prashant still with us?
Anil, I was just wondering whether one should extend Dr. Banerjee's logic beyond IBD to say, when in doubt, go for the vaccine early. Or anything.
I would completely agree. I think in India now, we should dispel all discussion, and for the audience who are still watching late Sunday night, the message is this: vaccinate, vaccinate, it works. And I always love that picture of that smallpox vaccination, New York, because I think once we do that, that's the only hope we have. We'll have variants.
Can I ask a basic question to Dr. Saurabh? Saurabh, you said 60% of Indians will have herd immunity, which I believe maybe even more than that. Now, if you want to just blindly vaccinate, the very fact that you have antibody, will that interfere with immune response? Should we do an antibody testing before vaccination?
Well, so at least from the data and the studies that we've seen, people who have got COVID and then received a dose of vaccine, they seem to have the similar titers as patients or people with two shots of vaccine. And I think Dr. Banerjee did show it in one of her slides where one dose of vaccine plus COVID is equal to 2 doses of vaccine. So I'm not sure if that happens, but I think,
See, but the recommendation is if you have had COVID, you should not have vaccination for at least 90 days. The reason is if you have antibodies, any incoming antigen will be neutralized. Hold on till 9 months. The reason for giving the vaccination in COVID protected individual is to take care of the variants as well as to have a secondary boost, immune boost.
Yeah, probably after 3 months. I suppose if the titer weans off, that's probably why we're doing it after 3 months, that it will not be effectively neutralized when we give the vaccine. Is that? Yeah.
I think all discussion has to have two parts in our country. One part is the science and pure science, and the second part is the practicality and feasibility. And I think in the current scenario, if somebody, we cannot afford to have everybody tested for antibodies and then decide on how many doses. So I think I completely agree with Dr. Arora. There will be cases who have been asymptomatic, not checked, already have antibodies. But I think even if they take 2 doses, what is the harm? Because checking everybody may not be a feasibility.
Suppose you have antibody, you don't need it. If you have neutralizing antibody, why do you need it after vaccination?
I completely agree with the science. But then checking everybody for antibody, then deciding on vaccination, will that be a feasibility is what I'm thinking of.
But till there is no vaccine, at least you can have the antibody tested, as Dr. Gurkirpal said. There is big queues in Delhi for getting vaccination. There is no vaccination. Dr. Gurkirpal, do you think we should do the antibody testing till then?
Well, the simple answer to this question is that a country like India cannot afford the luxury of testing of the kind that we would like to theoretically think of.
So I have actually got in my biorepository patient samples post-vaccination IBD patients. But then the cost of checking for all the antibodies for those patients, we are just hopeful that someday we'll have some funds, but it's still in the repository. So
Dr. Gautam can fund the project.
Yes.
I think
the important thing is the
very happy to.
From the logistic point of view, because there is vaccine shortage as well as issues regarding testing as well as the cost as to who would foot the bill, the best thing is to follow the 3 rules: wear a mask, rub your hands, and keep safe distance. We are getting used to it. It's already more than a year that we've been doing it, and it's going to become a routine part of our lives.
I think we have alarm bells from the organizers. May I hand it over back to Ashish to thank everybody and conclude the session.
Thank you, all the participants. Actually, this is the second part of the COVID vaccination webinar which we had. And I hope that we don't have any more webinars on COVID and this COVID subsides, the pandemic subsides. So I would like to thank all the chairpersons and the moderators as well as the speakers for all this wonderful discussion which we had. And this we had overshot the time by 1 hour, 20 minutes. I would also like to thank all the attendees. I haven't received how many of them were there, but I think they were in hundreds. And last but not least, I would like to thank our academic partners, that is Micro Labs, for their logistic support. And we'll soon announce you the next date for our webinar, routine webinar, monthly webinar, and the next recipient of the Dr. Sama Memorial Award. So with this, I thank everyone, and we hope to see you next time, next month. Thank you all.
Thank you, and good night.
And good night. Good night.
Goodbye.
It's a wonderful experience to me.